Okay, good evening and welcome to tonight's 2-hour study club with Dr. Ben Miraglia on airway dentistry, preventative, comprehensive, and aesthetic benefits. I am your host, Lauren Gates, and tonight we have the pleasure of having a co-host for the first time. Dr. Ted Gross is the Director of Study Clubs for the Greater New York Academy of Cosmetic Dentistry. So welcome, gentlemen.
Welcome to you. Thank you.
Thank you.
Yeah, good evening, everybody.
Yeah, I'm excited to be back. It feels like we got the summer off and here we are once again. So let's start off, Dr. Gross, by sharing how this collaboration with AHS and the GNYACD came about, which I know everybody is curious about what exactly that is.
Sure. Well, first let me say that I'm the Director of Study Clubs for GNYACD. And GNYACD stands for Greater New York Academy of Cosmetic Dentistry. And we're a branch of the American Academy of Cosmetic Dentistry. So as the Director of Study Clubs, I get to have a hand in choosing who we have for our study clubs. And I mentioned Ben to our board of directors, and they said, yeah, let's do it. So Ben is known, and they were looking forward to hearing something about airway. I met Ben, he probably doesn't remember this, but I met him at one of the lectures that he had given about 6 years ago at the Greater New York Dental Meeting. And I wrote a little thing here about that we used for a blurb on one of the emails. So let me just read that. 6 years ago, I listened to a lecture by Ben Miraglia, and it forever changed the way I look at dentistry. If you've ever wondered why dentists should be concerned about the relationship between dentistry and airway health, you must attend this webinar. You'll find it eye-opening. And it's a pleasure to have all you people here listening to this at this point. That lecture I went to by mistake, actually, Ben. I hate to tell you that. I thought it was about something else. And I was sitting there.
I trick a lot of people into my lectures, so I succeeded in tricking you in there too. Good, nice.
Yeah, I got in there. And I'm saying, damn, what am I doing here? And then I started listening. I said, wow, this is really good stuff. It's fascinating. And then as I left, well-deserved, well-deserved. As I left, I said, uh-oh, now we have a new paradigm. And now I got to do some thinking about this. And it's groundbreaking, it's eye-opening. It's a wonderful thing that you're teaching this. And I'm really looking forward to this evening.
Thank you very much, so am I.
Great.
Well, before I introduce Dr. Miraglia formally, because I know we have a lot of attendees who may not be familiar with Dr. Miraglia's work, I want to thank you and the GNYACD for sponsoring tonight's CE event. We're really grateful about that. And just some housekeeping notes, please stay tuned for the CE code at the end of our time together, and we'll send you a survey to fill out with that code. So let's kick it off and talk about airway. I am honored to introduce Dr. Ben Miraglia. Dr. Ben Miraglia graduated from the SUNY at Buffalo School of Dental Medicine. He has 26 years of general practice experience in Mount Kisco, New York, including 17 years of interceptive orthodontic experience, where his focus has been on early childhood growth and development. Dr. Miraglia lectures nationally on sleep disorder breathing, clear aligner therapy, and craniofacial development, and is on the board of directors of the American Academy of Physiological Medicine and Dentistry, also known as the AAPMD. He is also on the President's Council of the Northern Westchester Hospital, Mount Kisco, New York. Dr. Miraglia has been recognized multiple times as a leader in continuing education by dentistry today, and we're thrilled to have him once again. So Dr. Miraglia, why don't we go ahead, you can share your screen and let's begin.
Sure, let's see here. I got this. Let's make sure I get that right. Here we go. So did that pop up now? Did we get some?
Yep, it did, and just go into the PowerPoint view. And it'll be great.
Terrific. How's that? Title slide?
Very good. I'm going to go ahead and mute and turn off my video until you're all
Great.
set. If there's any questions, feel free to chat in the chat box and we'll address as many as we can. We do have a full list of questions just from the registration, but we will do our very best. And hopefully you'll answer a lot of them over the course of this hour and 15 minutes. So thank you.
Yeah, sure. Okay, very excited to be here. Thank you very much, Ted. Appreciate the introduction, Lauren. So we'll get right into it. There are going to be some children in this presentation, so I want everybody to be careful. No photos or video recording during the presentation, please. We don't really have permission to violate our patients' privacy rights, so I don't want the photographs of the kids or really any patient getting out past tonight's webinar. We have permission to teach with the cases. You have permission to look at them. We don't really have permission to post them anywhere else other than this presentation in tonight's format. So don't use your cameras and videos on anything, please. All right, so basically we start talking about dentistry, and today thinking about airway and thinking about OSA and the whole, airway dentist and or, dental airway conscious practice, or any which way you want to describe it. But we have a lot of sleeping and breathing going on in the dental community now, all thanks to OSA, obstructive sleep apnea. Well, adult obstructive sleep apnea, while that might be, attended to by the dental office today, where we have different appliances that we can make, and mostly in the mandibular advancement category, we have a pathway to get to OSA, and a lot of it begins as childhood sleep disorder breathing. So if we're underdeveloped as a young child, then underdeveloped jaws can give you an airway compromise, and that airway compromise can lead to, difficulty with our sleeping patterns. And so we talk about sleep disorder breathing as a generic category because it includes everything in the specific diagnosis category. So when we think about sleep disorder breathing, it's really anything other than normal, silent, and invisible nasal breathing. So if you're mouth breathing, or you're snoring, or you have upper airway resistance, or you have OSA, mild, moderate, all of those things are specific types of things. It's considered sleep disorder breathing until you actually have a firm diagnosis from the BSG or a sleep study. So if we think about our adult patients where the damage may have already been done, or there's a lot of damage that has occurred because we've been OSA for a while, but you don't have to get to OSA to have damage. All of the damage can be happening along the way. So even though you might get an OSA diagnosis at age 50 or 40 or 55, 35, it doesn't matter when you get it. It doesn't mean that's where your damage starts. Your damage began probably 2 or 3 decades ago in the early childhood years. And so we're going to build a nice puzzle for you as far as, where does this all come from? Because pretty much everything that happens in a human being has a cause. And there are pathways where human beings function properly, and then there are pathways where human beings can malfunction. And poor breathing and sleeping is a form of malfunctioning, and we will be, building a puzzle on how we got there. So when we think about the beginning of this, where there are children involved, and we'll start with kids, but we're going to show you a young child, a mixed dentition, the late teen, and then the adult, kind of 4 different age ranges, so you can see what's available in those categories to help our patients that have symptoms. But when we're thinking about kids, there is a long list of symptoms today. And pretty much everybody knows children in these categories. And whether they're in, in our own homes, in our schools, in our, practices, in the communities, these symptoms are fairly common today. So we'll zip through a list of symptoms that children are struggling with. ADHD, asthma, upper respiratory infections, ear tubes, bedwetting, nightmares, night terrors, learning disabilities, clenching or grinding of the teeth, restless sleep, waking often, small or delayed growth, anxiety, depression, daytime sleepiness, overweight, night sweats, gastrointestinal distress, as we loosely call reflux, emotional instability, mouth breathing. Oh, whoops, went too fast. Mouth breathing. Now, this list of symptoms are things that are going on because something's not working perfectly well. And when we have this list of symptoms, we have 2 pathways. One is to treat the symptom, which doesn't really offer a benefit for the short or the long term. And then there's the treat the cause, which is a whole different opportunity. So we're going to be building our puzzle as to how do we get to some of these symptoms versus, treating the symptom itself, or should we maybe take a step back and treat some of the cause that's happening here? So when we think about malocclusion, our world is malocclusion. So I live in the world of malocclusion. I treat the malocclusion. I diagnose the malocclusion. So malocclusion is my word, malocclusion, malocclusion, malocclusion. A bad bite. But there is a more common type of malocclusion, and that is the crowded. And so when you're thinking about malocclusion, crowding is the most common, and it's overwhelming. Most children grow up with a crowded malocclusion as opposed to a spaced malocclusion. So we see crowding as a very common, most common type of malocclusion. There are causes of crowded teeth. And so when you have crowding in your teeth, or you have that bad bite, you have an improper arch form and an improper arch width. So that your crowded teeth, your bad bite, come from a foundation issue. They're not the fault of the teeth. So that the teeth don't cause the crowding, they're the symptom. Crowded teeth are a symptom, but they're not the cause of the trouble. The cause of the crowding and or the bad bite is your arch form and width. That basically is the foundation. So the foundation is the cause of our problem. So then we start thinking about, okay, maybe we want to treat the foundation instead of the symptom, which is the teeth. So when we start to think about the foundation, we think about an improper versus proper arch form and width. And so this is a really nice, clean, clear picture of the difference between an improper arch form and a proper arch form, as well as an improper arch width and a proper arch width. So when a maxilla grows beautifully, you end up on the right side of the screen with a proper arch form and a proper arch width. You have a beautiful dome shape with a nice wide or spread out arch and a significant distance between the upper first molars. When we do not grow our maxilla beautifully, or the maxilla is underdeveloped, it will be narrow, vaulted, it'll be elongated, it'll basically be shaped like the letter V or an omega. Sometimes we use the word omega when the second molar pops in, because the second molar will pop in wider and it gives the curved shape of the omega symbol. And so we start using omega. So we go from a V-shaped arch in the early days to an omega-shaped arch when the second molar pops in. But either way, there's a very significant difference in the teeth. Of course, the occlusion, malocclusion, good occlusion. But then the one component that we may not have been thinking about early on, but now we should, and once you see the pictures, it's hard to not see it later, is the tongue. One of these mouths has a beautiful chamber for the tongue. So we imagine biting down and closing our mouth. Now, a human being is an obligate nasal breather. So when our mouth is shut and we're breathing through our nose like we're supposed to be, the tongue has to park in a chamber. So if we close these mouths here, one of those mouths, when it's closed, has a beautiful chamber for the tongue to live in, and the other one doesn't. So when the left side of the screen is closed, when there isn't enough room for the tongue, it is posteriorly displaced. And when a tongue is posteriorly displaced, it will interrupt how well the air will flow behind it. So we end up having this improper arch form and width be the cause of the crowding of the teeth, but there's more going on than just crowding of teeth. So when we think about improper arch form and width, it's the result of underdevelopment. And so inadequate development of the maxilla and the mandible is going to give you this trouble. And basically the underdeveloped maxilla causes crowding, but the underdeveloped maxilla also has an adverse effect on the position of the mandible. So we think about it this way: the mandible is the moving part. Maxilla is kind of fixed, but the idea is if the maxilla doesn't grow to its full potential, then wherever the mandible lands is incorrect. So the mandible only has one correct landing point, and that would be if the maxilla grew to its full potential. So a fully grown and fully positioned maxilla has a mandible closing into a proper position. Any level of underdevelopment in a maxilla, you have a mandible closing where it doesn't belong, usually trapped behind the maxilla. So an underdeveloped maxilla delivers a trapped mandible, or a mandible that is posteriorly displaced, or retrusive, as we might say. And next thing you know, that does throw things into a tailspin when you're thinking about musculature, TMD, condyle, disc. None of those things are correct with an underdeveloped maxilla. So when we're thinking about growth of the jaws, normal would be wide forward with a little bit downward. So a nice amount of width, a great amount of forward, and a little bit of downward, that's normal jaw growth and development. Abnormal growth, well, if we're not wide, we're narrow. If we're not forward, we're backward, but we get excess downward. So the underdeveloped mouth is basically narrow back, but a little longer. And it has a full title. It's called excess facial height malocclusion. And so excess facial height malocclusion is a description of underdeveloped jaws that have the narrow backward and downward component to them. And that is basically a lack of full and proper growth and development of the jaws. Now, to reset what normal looks like, we have to first find someone that's normal and growing ideally to be able to think about, okay, where should we be and how should we look when we're younger, because we don't see this very often. So if we're thinking about the primary dentition, say 3 to 5 years old, this happens to be an example of a 5-year-old, we would be looking for kind of 3 things to give us an idea that we're normally or ideally growing and developing. The first is that we have gaps between every tooth. So if a primary set of teeth comes in and has a gap between every single tooth, that's a good start. That's checking one box. Box number 2 to check would be you have a full view of the bottom teeth. And so in this bite, we have a full view of the bottom teeth. Now, those 2 things there give a good indication of some width. If you've got a gap between every tooth and you can see the bottom teeth, okay, things are growing wider and they're probably growing forward, but there's one other way to tell if we're growing forward, and that would be by taking a profile x-ray. Because on this profile x-ray, we can see the primary set of teeth and the permanent ones beautifully underneath. And of course, we can find the nostril. And you can find the nostril and the air goes in, it goes up a little, then it turns around. It's like an upside down letter J. And so I'm using my pointer. Hopefully the mouse pointer is on the screen that you're seeing. But the idea is there's a tube here or an airway. There's the trachea in the neck, okay? And then there's this tube that connects, from the nostril to the nasal cavity, to the nasopharynx, the oropharynx, and the laryngopharynx. Now, all of that is a space, but the size of that space is determined by how the jaws are growing. So if the child's jaws are growing forward, this is a very wide open space. This is only 2 dimensions, but it shows in your front to back relationship here that you have a very wide space. So this child has a gap between every tooth, a full view of the bottom teeth upon closure, and a nice large airspace behind the jaws. This child is growing wider and forward. That would be normal or ideal growth and development. In our practice, because we see that so rarely, we refer to it as an endangered species, and some days we call it a unicorn. So if I get to see for every several hundred primary sets of teeth I look at, there's one child like this. So we would find one child that has a gap between every tooth, a full view of the bottom teeth, and airspace behind it. While that child is one out of several hundred, that child also comes in without a medical symptom list. So they do not fall into the categories we listed on the first slide where there were symptoms that children are struggling with. A child like this will be nose breathing. A child like this will sleep well. A child like this will not have a symptom list, and you then have a set of primary teeth that, with good jaw growth and development, has great breathing, great sleeping, and is healthy. Unicorn is what we call that today. Now, that child, without intervention, one day is going to be 12. Now, a 12-year-old walks in, and what would we find? Well, we would be looking for a proper arch form at a proper arch width, and all of the teeth generally where they belong. Here's someone who got to 12 years old, and all their teeth went right where they belong. And it looks like this, that class 1 connected on both sides. You have a beautiful, beautiful shallow vault where the tongue fits right in. The maxillary, palate area looks like an imprint of the patient's tongue. So we know the tongue's been living in there beautifully. Got the beautiful bite connected nicely. You have proper overbite, proper overjet, canine protected, posterior intercuspation without interference. You have your arch form and arch width to establish a beautiful foundation for these teeth. So when you look at this set of photographs for this 12-year-old, you start thinking about, well, how many 12-year-olds look like this? How many 12-year-olds do we get look like this? And then you can say, wow, you have a typodont, perfect textbook occlusion. You do not need orthodontics. This is not a need for orthodontics. This is someone who has, if we looked at those photographs, you can find, there's a millimeter of space in the upper arch, and maybe you have a couple of little turns on the lower incisors to correct, but there's no need for treatment here in the ortho category. The idea is, this patient has full foundational growth and development. All of their teeth go where they belong. And then you think about, okay, how many 12-year-olds do we get to see that match this? And it's pretty much the same rate. When we have to look at several hundred 12-year-olds, there's only 1 or 2 that look like this. Very few children get to this point on their own. And then this actually is normal growth and development. So while this is perfectly normal, it's totally uncommon. More often than this, we see crowding and bad bites. That's super common, but super common doesn't mean normal. So this is your ideal normal growth and development. Now, if you've got all of that incredible foundational growth and development, all of your teeth where they belong, you're going to have a 12-year-old that doesn't have symptoms because they will be an obligate nasal breather. And if you're an obligate nasal breather and that breathing is without resistance, meaning silent and invisible, you'll sleep well and you'll be ready for the day the next day. You won't have symptoms. So then we think about why. Why are most of the kids we see underdeveloped? Why do we see maxillary and mandibular underdevelopment as incredibly common? Incredibly so common, it's got to be like 99% in my office, and I'm getting to see several hundred kids a year. But when you think about the level of that crowded, maloccluded type of bite in kids, it's super common, but it's not normal growth and development. So we want to know why. Well, to get the answer for why you have malocclusion in the first place, you go to anthropology research. So Dr. Robert Corcini is an anthropologist. Dr. Corcini is not only an anthropologist, but he's a head and neck expert. And a little more specific than head and neck, Dr. Corcini is a malocclusion anthropologist. And so he spent almost 4 decades doing research on malocclusion. And so with books and journal articles, fossil and population studies, animal testing, and twin studies, basically he gets to publish a book, which is the culmination of all of his research and others like him. But I'm introducing you to him because he's probably the world's leading malocclusion anthropologist. So here's the title: How Anthropology Informs the Orthodontic Diagnosis of Malocclusion's Causes. Just digest that title for a second. How Anthropology Informs the Orthodontic Diagnosis of Malocclusion's Causes. So malocclusion has a cause. Underdeveloped jaws have a cause, and so we learn it from the anthropologists. So it turns out, prior to 400 years ago, there's little to no malocclusion in human beings on planet Earth, anywhere you go around the planet. You have little to no evidence of malocclusion in human beings. Jaws are fully grown, 32 teeth are present, and basically those teeth are upright in a vertical position. They come together and connect beautifully, and you have this well-developed bite that is uniform. There isn't variation. Now, prior to 400 years ago, when they say little to none, it's interesting where the little comes from. Prior to 400 years ago, you find little areas of malocclusion, and it's in the aristocracy grave sites. So when you're going through, when the anthropology is going through the fossil studies and going through doing the research on grave sites, it turns out that when you want to see underdeveloped, crowded malocclusions, you go to the aristocracy grave sites because that's where it all is. So the rich people have a different form of upbringing, and what happens then is the jaws don't grow, and if the jaws don't grow, the teeth don't fit, and you get your crowded, kind of ugly malocclusions showing up there. Whereas in the poor populations, those populations have a different form or pathway of growing up in the early years, and next thing you know, all of the jaw development is there, and all the teeth are there, and you have 32 teeth and beautiful developed jaws with little to no variation. So malocclusion is a new thing to the human race. Only within the last 400 years does it pop up. To get to the point where we are today, it's probably like 95% of kids have malocclusion, and then of course adults have malocclusion. All right. So what they learned from global population studies as anthropologists travel the world and collect data going forward and backwards through grave sites, basically they study a lot of isolated rural people where there is no malocclusion to figure out, okay, what are they doing differently? And the interesting component and the most significant component is that the breastfeeding is followed by a hard diet at a young age. So they learn immediately that, oh, the infant transitions from breastfeeding to a hard diet almost immediately. So the jaw muscles are being used at an early age. So what they learn in these populations is that there's little to no evidence of malocclusion or any type of inflammatory or degenerative disease. That's another interesting finding. That's the whole medical pathway. There's little to no variation. All of the jaw growth is uniform into a beautiful bite with 32 teeth, fully formed jaws, no variation. Now, a lot of these cultures, they get to study as they become exposed to Western cultures. And what they recognize is that the very first thing that happens to isolated cultures is trade for food. And as the food trade begins, it starts softening the diet. So they go from their natural tough diet to now that mushed, blended, softer diet, where all of a sudden, because of processing, preserving, canned, all of a sudden the shift towards softer foods takes over, and gradually an isolated culture becomes a Western or industrialized culture where the diet is then ubiquitously soft. So animal studies, this finding introduces anthropology to animal studies right away. They start doing hard, soft diet studies. They say, oh, wait a second. If an infant chews hard food early and these jaws are growing like this, we better start doing some research. So they pick up hard, soft diet studies. Basically what they do is they take a group of young growing animals, you divide them, and then half of that group is going to get its normal habitat diet, and the other half is going to get blended. It's going to get the same diet, but just blended. So mush, baby food, like we do. So the soft diet animals end up with smaller body mass, less dense bone, and this is body wide, not just the jaws. The entirety of the bone structure skeleton of the soft diet animal has less dense bone. But then what happens, of course, and this is natural, if you have an early soft diet, you'll have smaller, weaker oral musculature. And if you have smaller, weaker oral musculature, you get a narrower maxilla, a smaller mandible, a thinner alveolus, and smaller condyles. So your maxilla and your mandible do not grow to their full potential if there isn't muscle activity being used appropriately. So you need strength of the musculature, but you also need proper function of the musculature. So strength and function go a long way to growing the jaws. And when you lose the strength, meaning weakness in muscles, weaker muscles compensate, and what ends up happening is we get dysfunction. So the early soft diet delivers the weakness. The weakness produces the compensation. Now we have dysfunctional musculature. when you have weaker dysfunctional musculature, the jaws don't grow the same. They become underdeveloped. And here comes the crowded malocclusions that we see. So malocclusion prevalence by generation, as isolated cultures become exposed to prepared, processed, preserved food, all of a sudden in the first generation, the malocclusion rate becomes 50% of the children will show it. So you have a rapid increase in malocclusion introducing a soft diet to a culture. But in a second generation, that number jumps to 70%, then third generation 85, and fourth it gets over 90. And the idea is in 4 generations, which is anywhere from 80 to 100 years, what you have is a complete softening of the early diet. So the transition from having breastfeeding followed by a hard diet, the transition is breastfeeding to a soft diet. Almost all of the early diet is soft in 100 years. And if the early diet is soft, you have malocclusion rates that are very high, but as well as that, you get variation. Variation increases because when you have weakness in the musculature, you get less bone growth. But when you have dysfunctional muscles, you get variable malocclusions. And then we use words to describe variation, which could be like the difference between having a very deep bite to having an open bite, or the difference between having a large overjet to a negative overjet, or a right side crossbite, or a left side crossbite, or a bilateral crossbite. Or you can name all the different ways we describe malocclusions. That's what it means to be variable, and variable comes from dysfunctional musculature. So here we have all of this happening thanks to that soft diet. So basically what the anthropology community knows is that when you have an early soft diet, you get changes, and dietary consistency and toughness promote proper bone growth and proper permanent tooth eruption, bringing about ideal occlusion. So that's the pathway to ideal occlusion, is proper jaw growth. So dietary consistency and toughness promote proper bone growth and proper permanent tooth eruption, bringing about ideal occlusion. When non-resistant processed foods become ubiquitous after industrialization, and the erupting and cuspal coordination of teeth lose the critical pathfinder influence of vigorous masticatory pressures, malocclusion shows a rapid rise. So we get malocclusion introduced to the industrial Western lifestyle change at about 400 years ago, and it creeps across Europe, it jumps across the pond, and it comes right across America. So basically we have malocclusion rises at the same rate in any culture as soon as they begin that industrial Western pathway of the early soft diet. All right, so if you have these underdeveloped jaws, what's the real problem? What's the result of having an underdeveloped maxilla mandible? Is it just the crowded teeth? Is it a bad bite? Is your smile's not nice? Or is there really a bigger problem that we should be thinking about? And it's well beyond our teeth are crooked or we have a bad bite. You got to pay more attention to what's going on underneath. And we look at our anatomy for this. So when we think about the maxilla, we want to be reminded that the maxilla makes up the floor of the nose and the lateral walls of the nose. And so the nasal cavity is mostly the maxilla. So maxilla holds our top teeth in, got it? But it's the triangle in the center. So I'm going to put my fingers up here. The triangle in that skull is, when we look in the mouth, we're seeing the palate. So if you're looking up, there's the palate. But when you're in the nose looking down, that's the floor of the nose. Well, the maxilla is the floor of the nose, and the roof of the mouth, they're one and the same. So palate and floor of the nose, same thing. The lateral walls, that's also the maxilla. So this triangle is the maxilla. If our maxilla is fully developed, we have a big triangle. But when the maxilla is underdeveloped, it folds up and narrows. So now you have the vault rising and the walls collapsing in. So this chamber becomes smaller. Well, that chamber is where the air has to flow if we're going to be a nasal breather. So the obligate nasal breather needs a big chamber here. Otherwise, we get this. And with airflow resistance through the nasal cavity, all of a sudden, we're going to have a problem there, because if the nose doesn't breathe well, then the mouth starts to breathe. But mouth breathing is unhealthy. And that's the starting point of being very unhealthy, is to start breathing through your mouth. So mouth breathing is probably the most unhealthy thing a human being can do. And it gets worse by worse by worse. So if our maxilla is narrow, it'll be narrow and vaulted. The two go together. So when you're narrow, you're vaulted. And that's going to collapse the nasal cavity. But that's just one view. We got to turn to the side. Well, when we turn to the side, we have to think about the forward growth, right? See, if the maxilla grows forward appropriately, we would have more color here. So we've got the nasopharynx, the oropharynx, and the laryngopharynx in these three colors. So if our maxilla is growing forward very nicely, there would be more color here. But if the maxilla didn't grow forward, there'd be less color here. Well, the mandible is the victim of the maxilla. If the maxilla doesn't grow forward, the mandible is behind it in all class 1s and 2s. So overwhelmingly, the mandible is trapped behind the maxilla. If the mandible is trapped behind the maxilla, well, the mandible keeps the tongue with it. So if the mandible is back, so is the tongue. If the mandible is forward, so is the tongue. So when the maxilla grows forward, the mandible follows it, and you have more airspace here. More color means more airspace. But when the maxilla is underdeveloped and backward, so is the mandible trapped behind it, which carries the tongue. And of course, you have less color here. So we have the nasal cavity, the nasopharynx, the oropharynx, and the laryngopharynx to consider. These 4 spaces are compromised or smaller when we do not get maxillary and mandibular full growth. And we lose the ability to grow the maxilla and the mandible during the first 2 years of life. Most of the maxillary and mandibular growth occurs from 0 to 2 years old. We get 54% of the growth during the first 2 years. We get another 15% from 2 to 4. So from 0 to 4, which we're at most risk for that early soft diet, is when we get the soft diet. And of course, we lose our ability to grow. And that's where we're supposed to have 70% of our growth take place. So with underdeveloped jaws, what's happening? When the maxilla and mandible do not grow to their full potential, the result is a child with a compromised airway. So the airway is a space, and that space is formed by the size and position of the maxilla and mandible. If your maxilla and mandible grow beautifully, you have more room for the air to flow. You can be the obligate nasal breather you're supposed to be. We meet a lot of 10-year-olds. This is a 10-year-old. This 10-year-old, of course, has nostrils. The air will go through the nostrils. It will flow through the nasal cavity. It will flow into the nasopharynx, the oropharynx, the laryngopharynx, and make its way to the trachea and then the lungs. That's a wide or good space. That's a very nice space. This child has a good airway. So that airway is like a garden hose, plenty of room. Well, this child is also 10. This is a 10-year-old. This child is not growing wider or forward, and there's a very big compromise here. If the jaw growth is not growing forward, we get a lack of space here. A lack of space can produce trouble for a child. We'll compare the two. They're both 10 years old, and they both have a class 1 bite. So since they both have a class 1 bite, they both must be healthy. Well, that's not correct. One child on the screen here, the problems began at age 2. They struggled to sleep through the night. They had their tonsils and adenoids removed early. That made little difference. Then, of course, at age 6, the diagnosis was made and medication was started. By age 7, a second medication was added. By age 8, a third medication. By age 9, a fourth. So one of these children is on 4 medications by the time they're 10 years old, and they still have not slept through the night. Not one night have they slept through the night. One of these children is that child. The other child has no symptom whatsoever, has absolutely empty medical history, no sleep disorder breathing symptoms, no type of nighttime issues, no type of academic performance, no behavioral issue, has nose breathing throughout the day and night, and can have, a good night's sleep without being fragmented. And next thing you know, you wake up, you're healthy and ready for the day. So of course, the child on the left is perfectly healthy without incident. The child on the right has been struggling since almost a little bit after birth. Now, this is what we see on the inside. Well, of course, that's an inside picture. What about the outside picture? Are they different? They're both 10. They're both class 1. Teeth connected, right? Which by now means nothing. But the idea is one of them has wider and forward jaw growth and has a jawline and has lips well ahead of the eyes. The other one has the lips directly below the eyes, has the jaws backward in such a way that even the neck is compensating and dropping out. This down here is not a genetic feature. When the jaws are backward, this is compensation. This has to move out of position so that the air can get by better. This is all compensation for better breathing. So the child on the right side of the screen is not growing wider and forward, and it not only shows underneath, but it also shows outside. So those children need a different approach than a tooth-focused approach. All right, sleep disorder breathing. Now, sleep disorder breathing, we were talking about it earlier. It's anything from mouth breathing, snoring, upper airway resistance, OSA. All of those things are sleep disorder breathing. If you're a nose breather and it's silent and invisible and it's all day and night, if you do that 24/7, 365, you're probably very healthy. But the moment you have nasal airflow resistance, there's a problem. And the problem is that the body compensates for nasal airflow resistance by mouth breathing. It will open the mouth to let the air leak in there. And that doesn't make you healthier. That makes the problem worse. So that kind of adds more fuel to the fire. So with a decrease in nasal breathing and an increase in mouth breathing, you will alter your biochemistry and physiology, not only during the day, but during sleep. And the altered physiology comes from the imbalance of the CO2, which is our carbon dioxide, the O2, the oxygen, and the NO, the nitric oxide. So when those three things are out of balance and you're breathing through your mouth, even though it's a compensation for poor nose breathing, it doesn't mean you're healthy. What happens is you have sleep fragmentation. Now, sleep fragmentation is a disruption of the reparative sleep cycle. That disruption occurs because your brain recognizes this is not good breathing. So this is triggered by the sympathetic nervous system on purpose as a fight or flight reaction, because you're supposed to be nose breathing without resistance, which kind of is described as, a silent and invisible nose breathing is a non-resistant airflow. Well, if you have that, then your brain stays in parasympathetic when you're sleeping, and it will clean you all night long and get your rest and digest going. But the moment you have nasal airflow resistance, it will trigger the sympathetic nervous system. And one of the first things that sympathetic nervous system does when you're not breathing well through your nose is it opens your mouth. Mouth breathing is from sympathetic drive. It's a fight or flight mechanism, and it's the beginnings of trying to improve your breathing. Only mouth breathing doesn't filter or clean or warm or humidify or prepare, accelerate the air for your lungs. So the idea is, if you have someone who's mouth breathing, all of a sudden you have someone who alters the relationship of the carbon dioxide, the oxygen, and the nitric oxide. And that alteration triggers another mechanism to try to correct that. And what you end up having is a battle of sleep disorder breathing. And so the battle of sleep disorder breathing is that your body's trying to fix something it can't. It keeps you in sympathetic drive for the entire evening, overnight, so to speak, and you wake up unrefreshed because now you have not slept appropriately. And if you haven't slept appropriately, you're not ready for the next day. So a child who is sleep disorder breathing has this struggle every single night. So if we take a look at a 3-year-old, we'll start early. We'll go from 3 to a mixed dentition, and we'll get to the teen, late teen, and an adult. So this is where we're going to find maxillary deficiency. It'll be rather severe. We have a sleep disorder breathing type of child, trouble falling asleep, waking at night. And at 3, of course, we're in primary dentition. But you can recognize from the photograph, even with the little eye bar trying to protect a little bit of privacy for these children, this is what maxillary deficiency looks like. And this child actually has a full class 3 bite where the lower jaw is ahead of the upper jaw at this point. But with the maxillary deficiency that's here, it's recognizable in the face. Of course, from the profile, we'll see this. Now, it's a very interesting profile photograph because while it shows us that the lower jaw is ahead of the upper jaw, we don't get from that a diagnosis that the mandible's too far forward. So there's a difference there. If you have a profile where the mandible is ahead of the maxilla, that doesn't mean the mandible is too far forward. And the evidence is in the neck. So because the neck is popping out or compensating or repositioning lower, that lower jaw is actually too far back. So what it does is it highlights how underdeveloped this maxilla is. This is a lower jaw that is too far back, and we have the crease at the corner of the mandible, retrusion and overclosure, and we have the neck compensating out because when this jaw goes too far back, the neck starts to compensate. We need that lower jaw coming forward. The upper jaw needs to go further forward. So even though we're looking at that class 3 type of bite, both jaws need to go forward in order to solve the breathing behind those jaws. So we have this type of bite sitting there. And of course, we're going to play with that child enough to know that that's the bite. That's the actual bite. The child's not posturing forward. They hadn't thrown their jaw, because I know how some kids do a cheesy smile when you ask to take their picture and they go like that. So this is the most retruded position that lower jaw can get to. This is her bite. So we have maxillary deficiency is what we have. And that's a really significant position to be at age 3. This will not correct itself. She's not going to grow out of this. This is going to be a progressively worse malocclusion because we do not have maxillary growth when we should have had a lot of maxillary growth. So now, in just 5 months of treatment, and in this particular case, using removable myofunctional guidance appliances, we can get the jaw to start, growing differently. So by basically reestablishing nose breathing, by getting the tongue, the lips, the cheeks, all of the muscles of mastication to start working properly, you can start redirecting the growth. So myofunctional guidance appliances do this. So as you start to redirect the muscles, you start growing differently. And this is just a 5-month difference. In just 5 months of redirecting breathing and musculature, we can get the maxilla growing forward. And so it's not just the maxilla growing forward, the mandible has grown forward a lot in these 5 months because now you have a difference in the entire neck and chin position. So the lower jaw is growing forward a lot, the upper jaw is growing forward more. So you have a really big difference in the jawline to the neck. And that's because the lower jaw is growing wider and forward. And then, of course, the upper jaw is growing wider and forward at a little better rate. And that's the design of it all, so that both jaws will grow wider and forward, but the upper jaw is going to grow at a pace that exceeds the lower to get that child caught up. Now, by the 1 year mark, which takes a 3-year-old to a 4-year-old, you have this bite unraveling, meaning the upper jaw is growing wider and forward, and it's going to get out past the lower at some point. So you could take a look at the 12-month progress, and it shows, ooh, all of a sudden, now the lips are almost even there, and you have the jawline showing up. You have the lower jaw growing forward. So wider and forward starts giving you the cheekbone appearance. Wider and forward starts giving you a full jawline appearance. Wider and forward shows a distinct head and neck. We're no longer kind of melting or blending together. So now we've got this full growth and development of the jaws, wider and forward, a child who can breathe through their nose and can sleep through the night and then not have trouble falling asleep, not have trouble waking up in the morning. A nasal breather throughout the night is going to be a child who is now experiencing a normal, appropriate sleep cycle and not be in a sleep fragmented or sympathetically driven sleep cycle. So by 1 year, there's a complete change in the facial structure. So even though the eye bar is there for a little privacy, you can notice the difference in the maxillary growth. So the maxilla is growing wider and forward, as well as the mandible growing wider and forward. The maxilla at an accelerated rate to catch up. Now you've got almost an equal lip line. You've got beautiful cheekbones. You have everything developing wider and forward. And you have what would be considered a really normal anatomy. And this is all in 12 months time. So now, of course, on the right side of the screen, we're probably 4.5, from 3.5 to 4.5. So things are going pretty well. Now, at this point in time, almost over. So we're edge to edge. We might be edge to edge at this 1 year mark, which means we're in great shape because we're only 4.5. And with that amount of progress and that amount of time, this is all going to go, very well over time. But you have this terrific change in the growth and development of the jaws. And, the idea is it's not about the teeth, it's about the foundation. And when it's about the foundation, it's about the breathing and musculature. So the object is to correct the weaker and dysfunctional musculature so that you can get your jaw growth and development back. Now let's take a look at a 9-year-old. So for a 9-year-old who walks in like this is a very unhealthy child. And so you could see right away how dry and chapped and cracked the lips are. So this is a child where the amount of overjet delivers an inability to even breathe through the nose exclusively, but you're going to see all the credentials in a second. But we've got a mouth breather here where all of a sudden the lips will be dry, cracking, peeling. So this child comes in at age 9 with a list, waking every night, has bedwetting. Enuresis is our bedwetting, which is 5 nights out of 7, night sweats, night terrors, snoring, mouth breathing most nights. Trouble with the alphabet. Now, when I say trouble with the alphabet, this child, like most others, is going to be working with an orofacial myofunctional therapist. Now, an orofacial myofunctional therapist is someone that deals with the breathing. So we're going to have exercises that are going to help us breathe through our nose better. They deal with all of the muscles of the head and neck. And with dealing with that, basically they're trying to balance the musculature again. So we need strength and balance out of the muscles of the head and neck, including the tongue, of course. The tongue is inside, and then all of our muscles of mastication are on the outside. So when we're dealing with an orofacial myofunctional therapist, they're going to be doing a diagnosis of the musculature, and basically they go through a lot of exercises. One of them is, saying the alphabet. Well, this guy at 9 is struggling so much that in saying the alphabet in 6 different times, he's making anywhere from 2 to 4 mistakes every time. So the best he can do in saying the alphabet at age 9 is making 2 mistakes. And so he's struggling enough to have done the 3rd grade twice. So here's someone who has gone through 3rd grade twice. At the end of 4th grade, the reports were not very good, and they thought that he would need a lot of help through 5th grade, recommending the list of tutors, et cetera, and that they even made the possibility of doing the 5th grade twice, which is kind of unheard of. But he's struggling because he's not sleeping well, and he's not sleeping well because he's not breathing well, and he's not breathing well because he has an underdeveloped set of jaw structures. So one of the things we're going to keep in mind here is that this child is already post phase 1 orthodontics. So some specialist had treated him for a phase 1 ortho and had done probably 15 months of phase 1 orthodontics. So the picture you're looking at is my picture. So I call it a before picture, but that's a picture of how someone looks after phase 1 orthodontics, but with someone else. We have this photograph. This is the profile. And again, it's my before picture, but it is someone's after picture. This is after phase 1 orthodontics. And we've got this picture, and this is the lateral x-ray. And this lateral x-ray here is my before, but This is the picture after phase 1 orthodontics. And you can see already from having looked at the other 2 x-rays I showed, following the nostril through, there's almost no room back here for air to flow. So we have a significant overjet. There's no question there's significant overjet. I can see that like anyone else can, right? Big overjet. And of course, we can see that narrowing of the tube, and it opens up at the trachea again, way down in the neck. It's a wide tube, but it's narrow all the way through here. So if you can't breathe very well, your mouth will open, but that's not going to improve very much because there's no room back here in the first place. So he struggles to sleep and breathe. Turns out, I think at age 6, the adenoids were removed. And the adenoids were removed. And sure enough, we meet him at age 9. We had to go back and take another look, and they grew back fully. It turns out if you remove the adenoids and then you still are a mouth breather, they'll all grow back. And so he had to have them removed a second time. This is an important picture here because there's a lot of overjet and there are different perspectives. Now, we just got some perspective on the previous little child where we looked at class 3. And I was talking about, well, just because it is a class 3 doesn't mean the lower jaw is too far forward. It just means the lower jaw is ahead of the maxilla, but it can still be that the lower jaw is retrusive. Here's a class 2. And class 2 does not mean that the upper jaw is protrusive. It just means it's ahead of the lower. Because if you take a look at the maxilla and the naso to oropharynx is non-existent, this maxilla is very retrusive. So the maxilla needs to go forward a lot and the mandible more because you have overjet. So this is a child who has a class 2, and much like the first child where you had class 3, class 2 does not mean the upper jaw is protrusive and needs to be pulled backward. The last thing he needs is the upper jaw pulled backward, and that would deliver less airspace back here. Now we go back to, this is the anterior view. So we're about to see a nice V-shaped arch where you could imagine the letter V coming as you look in here. So we're narrow and collapsed, and all the teeth have lingual inclination. Everybody's leaning towards the tongue. So of course, there's the overjet in the photographs that we saw in the lateral x-ray. And then we've got this nice V-shaped arch. Now, again, all of these photos are my before photographs, but they're also the photographs that are the culmination of post-phase 1 orthodontic treatment. These are somebody's after photographs. This is the culmination of doing phase 1 ortho on this child. And then they got this in here as the retainer to protect the accomplishment, I guess. So this is in here to protect whatever was accomplished. And if you start noticing now, well, we've got this lingual bar here, and oh, wait, the primary canines are not here. But of course, the child does have them. So we need 3 large permanent teeth to fit in this space, and we have no room for the canines. Now, those primary canines were taken out to allow these 4 teeth to straighten. So the technique that was used was called camouflaging. And if you take out the primary canines at age 8 or 9, you can line up these 4 teeth, and it looks better. These 4 teeth look better now than they used to, but we don't have any room. This is a subtractive technique and doesn't help any more eruption in the other teeth. This technique is usually employed right before the 4 bicuspid extraction case, because now you get this done and you're looking better here, but then there's no room for the teeth eventually. Now we can talk about this lingual control arch. Now, child's 9 years old, and we just cemented this, right? So someone cemented this in, we have to lock this in place. Why are we locking that in place? Shouldn't that child be offered an opportunity to grow? This is a 9-year-old who's underdeveloped. So they're not where they need to be. They need to be bigger. But any amount of development they could have is now taken away by restricting them here. This is no different than wearing the same size shoe from 9 to 10 to 11 to 12. What child can wear the same size shoe for really any more than a few months? Now you have this locked in from one side to the other. So the child is underdeveloped and now frozen in time right here. Until when? How long will this be in for? So these have to be removed immediately. So I take a lot of these out. It's the only way to get the child going in the other direction. So basically we have to treat this child appropriately, which is a foundation appropriate technique, not a tooth-centered technique. So he's going to need an orofacial myofunctional therapist. He goes back to the same ENT that took his adenoids. They were bigger than the first time, so we got to have them removed again. In his phase 1, we had to use an upper and a lower expander to develop his foundation and then get involved with some brackets, some wires, and then of course, with myofunctional appliance therapy, you can use removable appliances, but not fixed retention type of things when you're in your growing and developing years. In a phase 2, we would use clear aligners when it's 13, 14, or 15 just to do some alignment. So what we're looking at here is a 10-month change. Now, in 10 months' time, we've used an upper and a lower expander to kind of broaden and open up everything, get him caught up to where he should be at 10 years old. And then once that's appropriate, we could put on some braces to align the teeth. And then all of a sudden, 10 months go by, we want to start taking things out to let the other primary teeth fall out, let teeth come in. We would switch over to a guidance appliance. This whole time doing myofunctional therapy with a myofunctional therapist. But in 10 months' time, and again, this is just a 10-month difference, we go from struggling to thriving. And from struggling to thriving means that all of a sudden there's a difference in him in every category. We're going to see that in a minute. So here we have the profile view. All of a sudden, with appropriate jaw growth and development, things are growing wider and forward. And in just 10 months' time, we have lip seal at rest, which means, okay, now the nose is doing the breathing. And with the nose breathing comes better sleeping. And better sleeping comes different everything during the day. So all of a sudden, in just 10 months' time, we can see the change in the space here. Now, the original X-ray shows very little room behind the maxilla and the mandible, almost completely closed. But now as the upper jaw grows forward and wider, of course, the lower jaw will follow it, and this space starts to open. So what we've been able to do in just 10 months is by a multiple of 2, 3, or 4 times increase this space for air to flow. So the upper jaw going forward, the lower jaw going forward, both jaws getting wider, and all of a sudden the overjet decreases because the lower jaw is going to travel faster than the upper jaw forward, but both are going forward if we want this space to open, if we want to see a difference in the child. So by 15 months, all of a sudden we get to a point where we've got this broad, wide arch, proper arch width, proper arch form, a beautiful home for the tongue, and the lower is following it. So now in just 15 months' time, all of a sudden with expansion appliances, with guidance appliances, with myofunctional therapy, you have a conversion to nose breathing and proper muscle strength and function, and everything starts taking its place. So we went from a completely underdeveloped set of jaws with a horrific overjet and bite in a child who couldn't breathe and sleep with a long list of symptoms and struggles to all of a sudden here we are where this child sleeps through the night with silent and invisible nasal breathing, and now is thriving in school, has no issues whatsoever. So the bedwetting has stopped, the nightmares have stopped. This is a child who would describe dreaming and say, well, I used to have nightmares every night. Now I'm dreaming. I don't remember dreaming. It's like the first time I'm having dreams. I dream the whole night. So you get a kid talking like that. The night sweats stop. All of the things start to fade. And next thing you know, you have this mild class 1 malocclusion to contend with, which is going to be treated with clear aligners in the end. So all of a sudden that child's waking up. And next thing you know, you've got a child who can participate on a normal basis through school. And then of course in functions that are outside of school. When we get to phase 2, he'll be 13, 14 years old to be ready for clear aligners. And you can recognize we threw a few attachments in there. So the upper's got, I think, those 4 attachments. The lower, I don't think it has any attachments. So none were needed here. So you just put on a few, you start to shape these teeth. And we made 17 aligners for this. So we did about 8 months of aligners to develop that. And now you've got this, beautiful bite, school picture with the attachments are there. So in the middle of the school picture, when you're 14 years old, you get your picture taken. And then, of course, you have an A student, you have a kid who's participating on the basketball team, becomes a drummer in the school band, and all of a sudden he can behave normally and go about, his business in school and do very well and thrive. By the time you're hitting that, 14-year-old mark, you start getting the hairstyle going, you find the Axe cologne, and next thing you know, you're doing really well and feeling good and confident, and that's a different child altogether now. Eventually, you get to be a 17-year-old, and this happens to be him this year with his wisdom teeth erupting. And so you'll notice here, he has at the back of the picture, a little blurry, but the wisdom teeth are there erupting. And the upper ones are fully in, the lower ones are about half. But the wisdom teeth are going to fully erupt and be in function for him, which is kind of like most of the children we treat early. If we get involved early and develop the foundation and correct the breathing and the musculature, we get to enjoy the wisdom teeth erupting into function. So now it's greater than half of the kids that I get to treat have their wisdom teeth erupt into function, and very few get sent out to have them removed. You have a full, broad, wide arch with a beautiful smile, and all he's wearing is a clear retainer every night to maintain that. It's a class 1, both sides, and this class 1, both sides was developed without any elastics. There were no elastics used to fix this because we weren't trying to pull the maxilla back or pull the mandible forward. What we used, of course, fixed expanders, followed by a little bit of braces for alignment, followed by guidance appliances. The biggest key to success is the myofunctional therapy. What we ended up doing was recruiting the musculature and the breathing to behave normally to help develop the jaws. And when you do it at a young age, you can bring these kids right back to normal. So here he is, probably age 17, and you have a full set of 32 teeth and a broad, wide smile in a child who sleeps through the night with nasal breathing that is silent and invisible. He has absolutely no symptoms, hasn't had any since the age of about 10. And from 10 years old to 17, that's a nice 7-year run of health and stability. Now I get to a little bit older, let's get to 19. We're going to end up using here the same credentials where we have a malocclusion. This patient happens to have a TMD issue where The migraine, the weekly migraines are the biggest issue or chief complaint. Any malocclusion comes with some form of sleep disorder breathing. You have, as part of the therapy here, removable upper expansion appliances because we're 19, it's a mature bone, but we can still get it to grow quite a bit. And then in this case, there was a lingual frenum issue. And if you have a lingual frenum issue, what we call tongue tie loosely, that needs to be revised. The tongue needs to be free enough and mobile enough to get to the point where it can help develop the jaws. Otherwise, if it can't, if it's restricted, you don't have anything that's going to be able to develop the jaws and then hold it or retain it if you can't recruit the tongue. And we'll use some clear aligners as well. So removable expanders plus clear aligners are going to help this young girl. Her story it begins early because, from about 12 to 16, she's in 3.5 years of braces and then ends up at the TMD office with a TMD problem. And her TMD problem is, that she gets weekly migraines, and it was enough to pull her out of college. So this is the face of discomfort. You have asymmetry. What you have is compressed and activated muscles where they shouldn't be. This is not the look of relaxation. This is a look of someone who's exerting musculature activity everywhere to compensate for comfort. This is a position of probably the most comfort, which is discomfort. And so here is the look of unhealthy. So the history is that you have braces for 4 years. The TMD and the pain headaches begin during the orthodontics. And then, of course, there's jaw clicking and popping begins then too. And then the braces are removed just prior to about 15 years old. So during those 4 years, she went from all braces to some braces to 4 brackets on the front teeth, trying to get those straight. And they just kept taking stuff off along the way until she had more comfort. But, it was just a horrific experience for her. She goes to college, tries to get through college, can't get through, has to come back home. And then, of course, she's at the TMD office getting treatment with splints and things to kind of get more comfort. So the TMD specialist works on her, makes some splints, gets her to a point where there's some comfort, and then says, you should go see Dr. Miraglia and try to do some, ortho here. So this is the bite that was, the result of the 4 years of orthodontics. And so here we are after 4 years with the chief complaint is the weekly migraine. And then that's her biggest issue. So it's a TMD symptom. The idea is headaches are fairly common in the TMD category. So you get the migraine, and that's debilitating for a lot of people. It was for her. The laterals are undersized. Number 10 happens to be a microdont there, but we'll get to that later. So we have a very small upper jaw, and with that underdevelopment comes a need for maxillary development. So if we're going to diagnose improper arch form and arch width, and we want to make a big difference here, then we would make a measurement across the arch. I like to use the transverse measurement, teeth 3 and 14. When we first meet her, the measurement across that arch is 27 millimeters. So if she has 27 millimeters between 3 and 14, we're looking for something much bigger than that. We would use a removable expansion appliance for about 9 months to grow the maxilla. Then we would transition her into clear aligners to finish shaping the dentoalveolar complex. So grow the maxilla first, shape the teeth second, foundation first, teeth second, and it will change the anatomy of this entire maxilla. So we end up going from 27 all the way to about, I think 35 or 36. So the total expansion, we had about 3 from the aligners, but we ended up getting 5 to 7 out of the removable expander. So we have a big difference here from the first to the picture to the second picture. And it's an 8 to 10 millimeter change in the width of the maxilla. And all of that, again, a little bonding, we should point out, we did put a little bit of bonding on number 7 to give it appropriate tooth proportion. And number 10 got a little more bonding to get it to the same size as number 7. The lower teeth needed very little, just some alignment. We had just needed the need for alignment here. So this patient had an upper removable expansion appliance with the clear aligners in both arches. So an upper removable expansion appliance, clear aligners in both arches to do this. Now, the only teeth that had restorative dentistry are 7 and 10. 7 and 10 had composites, but all the rest of the teeth have the lighter appearance because of whitening gel. So when you're wearing clear aligners, you can throw whitening gel in there and you can have, a lot of nice effect with the gel. So of course you see a change of shade, but there's no other porcelain, just composite on 7 and 10. The difference really is in the foundation. So the foundation is completely different in the upper jaw thanks to a removable expansion appliance first. Grow the maxilla first, then coordinate the teeth. Now, the most important part of the entire thing is that she's now, and this is 5 years ago, so she's 5 years headache free. So within weeks of starting the expansive process in the maxilla, the headaches start to fade. And then by the time we got to 9 months with the expansion appliance, the headaches were gone. So she enrolled back in school. Over the last 5 years, she completed her bachelor's, got her master's, and she happens to be a teacher. And so she's now a school teacher in an elementary school. and absolutely thriving. She is now on the right side of the screen. You can see happy, comfortable, no more headaches, no more TMD symptoms, has a beautiful bite and smile that she can eat and bite and chew anything she wants. She does not have a splint or a night guard. She just wears a clear retainer every night to kind of hold the alignment of the teeth. The jaw growth will remain because you delivered in the lingual Frenum Revision and the myofunctional therapy, you deliver the tongue to take the position to support and hold everything on the inside, and that keeps the entire maxillary growth that you delivered in place by recruiting the tongue again. So all of that good growth and development here makes a big difference in the smile line. So again, the only two teeth with a little bit of aesthetic bonding are 7 and 10. Everything else is just whitening gel. But there's a huge difference in the width, and you can tell by looking at the alveolar complex that the maxilla is bigger. And the maxilla is bigger, and age 19 to 20 was the 9-month process of growing it with a removable expander. Grow the maxilla, that allows the mandible to close in an appropriate position. When the maxillary arch is developed appropriately, the mandible can close appropriately. That sets in motion the musculature to be right, the condyle to be right, the disc to be right, the eminence. Everybody's happy. Once it's all happy, you lose all your TMD symptoms. So as a routine, we treat the TMD patient, regardless of the level of symptom or the list of symptoms, we treat them with maxillary development. And so for the past 8 years now, all I do for TMD patients is maxillary development. I do not make night guards. I do not make splints. And we treat every patient, regardless of the list of symptoms or the severity of symptoms, the full resolution of those symptoms with maxillary development. So that's a really happy patient. And then we'll get to an adult. How about 41? What if you're 41 and you have a malocclusion with TMD and sleep disorder breathing, and you can use clear aligners? Well, at 41 years old, the chief complaint for this gentleman is that his jaw gives him trouble with just even a little bit of talking. It starts to fatigue and hurt, and then chewing. Even just into a little bit of chewing, his jaw starts to fatigue and hurt. So he can't do lots of chewing or talking without experiencing TMD symptoms. This is the picture of unhealthy. So when you see someone who looks like this and they have their lips separated, well, now they're breathing through the mouth. That is compensation. And then, of course, we're going to talk about that bite we're about to see, which is, we could describe it as edge to edge or narrow. We'll see the profile in a minute if you want to label it class 3. Either way, you have an underdeveloped malocclusion. This is very narrow. The teeth are all lingually inclined. That, of course, takes away tongue space. Well, we talked him through a consultation where I would have loved to have used an upper removable expansion appliance first, because I felt like we needed a lot of room, for that tongue and also for his bite to be corrected. And he just knew that he couldn't wear an upper removable type of expansion appliance according to the terms that would develop the maxilla appropriately. So why try something you can't do? So we defaulted to clear aligners. So I ended up using clear aligners alone. And of course, you could see he really enjoyed the whitening gel. So in his case, because we were edge to edge anterior, we had to open up, meaning we needed wider, but we also needed forward. And so when you come in edge to edge and you're edge to edge, but you're narrow, there's a fair chance when you start to widen the upper jaw, the lower will come forward. So he probably was a very nice full class 3, but not fully expressed because of the narrowness of the maxillary arch. So we have to anticipate that as we open up the width, the lower jaw is going to want to come forward. And it turns out this amount of development, meaning wider and forward, opens up a chamber. Now, interestingly, there's the chamber for a whole new tooth, but he has all of them. He's got 32 teeth. He was able to get all 32 teeth erupted into a narrow arch. So it was narrow, but he still had all 32. If we're going to develop that maxilla bigger and he has no crowding to start, well, if you don't have any crowding and you're developing the maxilla, you're probably getting space. It's very natural to put it behind the canine. You have a premaxilla section and then you've got your posterior maxilla. That's a natural place where spaces tend to want to open if you give them appropriate stimulus. We can also then make a tiny little Maryland style bonded ceramic bridge. So we talked through implants. The expense of putting them in wasn't really in his budget at this point. So we went with a basically bonded ceramic Maryland style, and they're prepless. So totally prepless. We can bond those in. However much time you get out of that is appropriate. Meanwhile, they've already been in, this is 6 years now since we did this. So 6 years ago, we've got them in for 6 years with no trouble. He knows at some point, if they do come off, we can always make a new one. You could try re-cement. That doesn't usually hold very long, but you can either try re-cement, make a new one, or you can consider an implant at any point in the future. So we're already 6 years into these. But the lower arch didn't need too much, just upright the posterior teeth, right? Full uprighting, give the tongue more room, align the anterior teeth, and the lower needed very little, but the upper needed all that good development. Now, with all of that good development, he ends up with just a a slight overbite overjet, which is terrific because that's all you need is a slight overbite overjet. It's interesting how we went from edge to edge to a slight overbite overjet, and yet that entire anterior segment was brought forward enough to build a beautiful extra canine. So this gentleman not only has 32 of his own teeth, he's got 2 of mine. So this is 34 teeth in here, but it's able to develop the full position of the maxilla to allow the mandible to come forward and land where it belongs. That maxilla was so narrow, it trapped his lower jaw back. Even though he's edge to edge, the lower jaw is trapped back. That accounts for all of his TMD symptoms. So you want to resolve TMD symptoms, you got to allow that lower jaw to come forward where it needs to be so everybody can line up. Now you go from that edge to edge bite and undesirable smile to a beautiful broad wide smile that's just natural and someone who has no discomfort while talking or chewing. And now he can talk all he wants without fatigue. He can chew all he wants without fatigue. So he has a 6-year run without a single symptom on any given day during the 6 years, totally happy, totally healthy. And that's the change from here to here. And this was done with clear aligners. Now you can see the difference in just taking the photographs naturally. We never ask, I don't do any stage photography. So I've never asked a patient to come in for a photo with fix your hair or do your makeup or put on a nice shirt or wash your face or shave or nothing. We just take photos as they walk in. But you can tell the difference on the left side of the screen, someone who is unhealthy and struggling. And on the right side of the screen, someone who is comfortable, happy, healthy, and thriving. And all of that came from maxillary development. Now the profile is significant. Before, he was so narrow and edge to edge, and his bite was, that every bit of the malocclusion we've been describing, he basically didn't have any lip seal at rest because the lower jaw was kind of in a position like this. But all of that upward development allows him to close, and then at rest, his lips can touch. So all of that upper or maxillary development not only allows for a really nice aesthetic smile, it allows for a beautiful lip seal at rest. You can then be your nose breather you're supposed to be, but you get all your comfort back. So now the maxilla is no longer a criminal to the mandibles being the victim. Now his maxilla is appropriate, the mandible is appropriate, and then everything behind it is happy. The muscles are happy, the condyle is happy, the joint is happy, the disc is happy, everything's happy. Same as all the other patients, they just wear a clear retainer to bed. A clear retainer to bed keeps your tooth alignment. And then when your tongue is brought to fill that space and behave itself appropriately, then your tongue is the scaffolding that maintains all of the growth and development that you did. None of the patients are going to shrink back to what they were. So we don't have the experience of ever having a TMD symptom recur or come back. The patients are treated to full TMD resolution. And then over time, they just enjoy comfort and stability going forward. So I mentioned a few things in here, and it does have to do with collaborative care because it turns out most of the patients do need an orofacial myofunctional therapist. And you can think about speech language pathologists too, in some of the cases where the children could benefit from a little bit of speech language pathology. But the orofacial myofunctional therapist is important because anytime you're looking at a malocclusion, your cause is soft tissue dysfunction. Soft tissue dysfunction, muscle weakness, and improper muscle function. That's what soft tissue dysfunction is. So if you have soft tissue dysfunction, that should be, how you treat. You want to treat in the cause category. So you want to work your cause through the soft tissue dysfunction. The orofacial myofunctional therapist is a valuable, member of the team there. You could think about the ENT, the oral surgeon. You can talk about pediatrician, you can talk about physician sometimes in some of these cases, chiropractor, physical therapist, craniosacral therapist. A lot of times the malocclusion is so bad that it changes your posture. If it'll change your posture, which obviously comes through the breathing, as you kind of fade from nose breathing to mouth breathing, the head gets postured forward to allow the air to flow better. So you end up then having your shoulders get more built, your head is coming forward. And then if your posture gets off, you need that corrected as well. So this list can grow pretty well, but you need someone on the list who can work with the musculature. So it's either going to happen in office or at the orofacial myofunctional therapist's office. Then you need someone on the list who can do a Frenum revision, because it turns out the more you do quantitative analysis and diagnosis of Frenum, the more you recognize most children have a Frenum issue. And if you realize most children have a Frenum issue, then it shouldn't be far after that you recognize, oh, most adults have it too, because that's just a grown-up child. So you have most people showing up with Frenum restrictions. And interestingly enough, you have a stack of research that shows Frenum restrictions or restricted mobility of the tongue lead to underdeveloped jaws. But underdeveloped jaws are a risk factor for sleep disorder breathing or worse. So you have those 3 dominoes are connected right in a row. So we definitely want to take care of the Frenum, starting by diagnosis, then of course treatment, any type of Frenum revision comes with myofunctional therapy. So we've got this list of people we can collaborate with to try to get the best results out of, our treatment. In the end, what we're looking for is foundational growth first, tooth coordination second. And in the foundational growth category, we're looking for a transition from mouth breathing to nose breathing. And we're looking from a transition from muscle weakness to strength and muscle dysfunction to proper function. And if you have those type of items corrected, then you get to enjoy the results that you're seeing tonight, a change in patients going from unhealthy to healthy. It's not just about having a terrific smile, which is what everyone's looking for. And there's nothing wrong with having that on the list, but you can have foundational growth and comfort and health and a beautiful smile all lined up in there. And you don't have to have a TMD symptom if you don't want to. There's a nice video that you should watch, but I won't play it now. I'll just give you the site to go to where you can watch this. And it's called The Story of Headgear. And so what you saw in a short time frame tonight is what's called expansive orthopedics or orthodontics. So you were looking at expansive technique or additive technique, growth and development technique. And then this video actually is a 6-minute video. It's The Story of Headgear. It's the history of retractive and extractive orthodontics. And this video was put together by lay people just to bring awareness to the fact that you have choices. You don't have to do extraction, retraction. So there's no need for extraction or retraction. It's just a choice. There happens to be an entire world of expansive orthodontics. And for me, it's the last 18 years of providing expansive growth and development type of orthopedics and orthodontics that deliver children who have wisdom teeth that erupt into function as opposed to having them extracted. So the goal is to not only get the first 28, which is very easy, it's the 32. You want all 32 teeth, but the only way to get to all 32 teeth is having full growth and development of the jaws. This little video is tremendous. So you go to www.rightogrow.org. And when you go to rightogrow.org, this is a YouTube video. You can just pull it up on YouTube. You can watch that, and it's very nicely done with the research. And then you can watch the video, and then you can always read the articles because they have all of the research articles citing how there's the opportunity for growth and development early, and extracting teeth and headgear to retract teeth can produce trouble with the airway. And obviously, if we're going backwards, if we're narrowing back or going backwards, you're probably giving the tongue and the airspace a smaller venue. That's trouble. Whereas if you're going wider and forward, you're probably giving things more room, and that's always good. So good things happen when you're going wider and forward. Bad things happen when you're going narrow and back. Short story is, this was really nice, kind of a public service announcement put together by lay people to demonstrate the difference between expansive and retractive orthodontics. So thank you very much for your time and attention. I know we're definitely going to have some questions, and we'll do some Q&A. We'll do some chatting now. I think others are going to join us for the Q&A.
That was amazing. I can't tell you how many times I have seen this, and I always pick up something else. And what I'm really excited about is that child that you showed us, the unhealthy child. I now got to see him healthy how many years later. So to me, it's really a thrill to see the work that you do and the stages that you're able to share. Dr. Gross, why don't you, I know you probably have some questions that you want to address, especially coming from a cosmetic point of view. Why don't you go, and we'll have a little bit of a panel discussion, and I'll address some of the questions on our chats and question.
Sure. Am I on?
You're on.
Yeah, I hear you.
Okay, great.
Dr. Riley, why don't you stop your sharing your screen just so it's a little bit bigger?
Sure.
Okay, let's do that. Stop sharing. Got that?
Very good.
Oh, yeah.
Did I get it? Okay.
Yep, we're good.
Yeah. Hey,
Terrific.
that was great, Ben. Really appreciated that.
Thank you.
Like one of those movies you can watch over and over. I was really fascinated when you talked about the unicorns that are 1 in several hundred that you get to see that looks great. That means that there's so many people that are bypassed by this, that end up with lives that are much less than what they could be. Now, how is it possible in our day and age to make some changes in that? I know nursing is one of the key issues. Women are working. My wife pumped and she fed my son that way. That's not the same as nursing. So that's a big issue. Soft foods is a whole industry. Pediatricians, do you speak to pediatricians much, or how does that go?
Yes, and so a long time ago, I went and asked our own pediatrician, do you ever do lunch and learn? They said yes. I ended up going to get a projector, a screen, laptop, put it all together. I brought it in there. I brought some dessert in to keep their attention. And so I started showing them what we do between age 3 and 11, because there's a lot to do between 3 and 11 to redirect all this. There's no reason for a child to be breathing poorly and underdeveloped for all those years when all of their cognitive and behavioral function is happening or being disrupted. So why not fix it earlier? So we do treat from 3 on. So as soon as we see the problem, we fix it. Well, the pediatricians, it was very receptive. It was received well enough that they invited me to do the grand rounds then. So years ago, I was going in like quarterly on a Tuesday morning from 8 to 9, and they would bring all 30 of the pediatricians in the community in for a meeting. And I got to share an hour of work and show them, here's what we do at these different ages early. And what I came to learn from it was that the pediatricians knew just by seeing the mouth, like something's wrong there, you know, but they were trained to wait until age 12 to send them to the orthodontist. So the kids are, but meanwhile, you're 3, you're 4, you're 5, you're 7, you're not sleeping through the night. You have this list of symptoms, you're struggling in school. If you're not breathing well and sleeping well, then all of a sudden, all of this is being missed. And you go to 12, you're getting your teeth straight. That doesn't solve, straightening your teeth does not solve the foundation when you're 12 to 14 years old. The short story is they were very happy to know someone could do something about this earlier, and they started sending the kids. So I get a lot of referrals from the pediatricians now. They say, oh, you know, your bite probably has options today. Why don't you go talk to Dr. Miraglia, even though they're 4, 5, 7, it doesn't matter. So that helped me a lot. And anywhere I teach, I try to encourage doctors, if they're heading in this direction, talk with your pediatricians, because if they knew that you could help a child earlier, they'd be happy to send them to you. The pediatrician is of the mindset they'd like to help the child too.
Mm-hmm. That's great. You know, you talked about aesthetics, and you know, this is the Academy of Dental Aesthetics. I remember I used to do cases, crowding cases. I'd refer in to an orthodontist, and you know, hope that they don't do extractions if they did orthodontics. And then if they didn't do orthodontics, we'd end up having to widen their smile artificially, veneers, and do some enamelplasty and make them look great smiles, but we weren't helping their airway. And that's got to be something that we really pay attention to, number one. And this lecture is great.
I appreciate that. Thank you.
Yeah.
You can have both. You can have more tongue space and nice looking teeth too. You still get to do the veneers. You still get to do the aesthetic dentistry. You know, just give the tongue more space first. You probably end up with a different outcome. Sure.
Like with the expansion, quite often you have little gaps that can get filled in, and you can do the little bonding there. And
the good news is that most patients come in crowded. So when you're developing the foundation, the crowding is fading away. I made it a point to show you a case where there was no crowding and how creative you could get in developing the anterior forward and the posterior wider and make an extra tooth. But it solved the entire TMD issue that he struggled with for decades.
Sure. Now with the baby boomers and whatnot, they're looking for aesthetics, and they're older, maybe 60s. How do you feel about crowding in baby boomers?
Oh, well, we have the same techniques. You know, if we need to grow the foundation, you use removable expansion appliances first, and then address the teeth second. So typically an older patient's going to get removable appliances first, followed by clear liners. That's a really nice technique. But myofunctional therapy can be done at any age. Frenum revisions can be done at any age. Some of the older patients will visit the ENT, because if you let it go long enough, you might actually have a deviated septum in there to find. And you could also have growth. If you have tissue overgrowth in the nasal cavity because of decades of poor breathing, you might need some polyps removed. You might need the septum repaired. And getting an ENT to help you with the nasal cavity is nice, because then you can draw the air into the nose better. And if you help out with tongue space, that's a really nice combination. But just so you know, it's not a 50-50, by the way, as far as nose and tongue space. The tongue is really 90% of the problem. The nose is only 10. But when you have a deviated septum and it will interfere with airflow, it's nice to have the last 10% of it. So you may as well do the whole thing.
Have you had any success with those patients also if they have CPAP or
Sure. Sure. They keep using it throughout treatment. You know, if you have a CPAP, you should be using it throughout treatment. And your goal isn't necessarily to cure their OSA, but you're trying to solve the things you can solve, which is going to be foundational growth and development until the tongue has enough room, Frenum revisions as needed, myofunctional therapy as needed, relieve all of the crowding, of course, in a non-extraction expansive technique. But the more you can develop the jaws, the more the patient will improve. And then the idea would become, well, how much change do you get in the AHI? Can you get someone from severe to moderate to mild or mild to none? And then the next step is, what about the ENT? What about the Frenum, the myofunctional therapy? When you put all of it together, there's a really good chance you're going to take that patient's diagnosis down. And if you can ratchet it down, terrific. Are you going to have some patients full resolution? Absolutely. Not all of them, but some of them, yes.
Yeah.
But everybody gets improvement, which is nice.
Yeah, super. Why don't we, are you ready to move on?
Yeah, there's plenty of questions. I'm going to kind of jump in.
Sure.
And feel free
Yeah,
to, we have a lot of time, which is wonderful.
We got time. We got
We
questions. We got
we
time.
do that on purpose, so we
Oh,
can
that's
kind of
super.
breathe a little bit. I know sometimes then you feel like you're against the firing wall here, so
Oh, we're
take a
good.
deep breath. There was a question about the midline. Do you attempt to align the midline and upper lower as well for TMD patients besides maxillary development?
No, never. In fact, midline is not part of a diagnosis. So a midline discrepancy is not a difference between healthy or unhealthy. And so there's no such thing as a human being who's symmetrical, right to left half. And so when you're thinking about teeth and or midline, starting at the midline and working your way back, that has a name for it. It's called a denture setup. And so when you're setting up a denture for an edentulous patient, you start at the midline and you put the teeth in. But that's a denture setup. That is not growth and development. So we do not use midline as a diagnostic tool because it is not, believe it or not, midline coincidence is not even on the list of criteria for a board certified healthy occlusion. So there's a long list of credentials for a board certified healthy occlusion. Midline coincidence is not one of them. So because midline coincidence has nothing to do with health whatsoever and is strictly aesthetic, I'm never looking to make an upper and lower midline coincident unless the patient walked in and it's their chief complaint. But in 29 years of dentistry, and a lot of people, 18 years in the orthopedic orthodontic delivery, I've never had a patient walk in and say, I want these two lines equal. Now, sometimes you get it, yeah, but if it happens naturally, I don't mind saying, oh, look, we even improved that at the end. But I would never diagnose a midline discrepancy and then teach a patient I have to have that lined up for a healthy bite. That would be incorrect. And it would be also fruitless because it doesn't change the symptoms. So I've never attacked the midline, so to speak. I do not make it part of the diagnostics, and it's not part of having a healthy occlusion. And I'm now 8 years into treating TMD exclusively with maxillary growth and development. And in none of those patients do we have any recurring symptoms. And some of them are now 7 years out of treatment, which is really nice to see that you can develop the upper jaw, relieve all of the symptoms, and you do not have to have a coincident midline for any type of healthy occlusion and or healthy human.
Do most of your patients come by way of TMD?
A fair amount of them show up for TMD, yeah. So most of them are second, third, fourth, eighth opinion because they've been told they have to do this, that, or the other thing, and they don't want to hear all that stuff, and it didn't sound good. So they end up in the office. But I have a lot of direct referrals from docs who send me their TMD cases for orthopedic and orthodontic treatment because they know once they're stabilized. And so there are offices that do a lot of TMD stabilization, meaning splints and or therapy to relieve or calm down, but that's not a cure. So then they'll send them to me and I'll do the ortho. None of those patients have ever gone back to a splint or a night guard or anything like that.
That's a great motivator, the pain.
Oh yeah, it's amazing when a patient is happy and they haven't been for 2 decades.
Right.
What they feel like.
I think that becomes an issue with if somebody just has an airway issue, they might not want to go through the whole treatment process. They might not be motivated to do that.
Yeah, it depends what the symptom level is. Yeah, you have
Yeah.
patients who are very interested in attacking their symptom list, and then we have met people along the years where they're mostly interested in their smile. And that's fine. You know, the patient has a chief concern and it's their chief concern. So the good news is if we talk about it nicely in a consultation and we figure out we're on the same wavelength and we would like to do these things, then you get all of it. You can have a nice smile and also be comfortable and happy and lose that sensitivity in your teeth and be chewing whatever you want and have, you know, unrestricted stability without discomfort in every category. And if you just want a good looking smile fast, we'll talk about it.
Sounds good.
On the last patient where you created the spaces, you recommended removable expansion appliances. Did the aligners only create alveolar expansion?
Yeah, that last case was aligners alone. So we talk about it as being dentoalveolar expansion and change. Yeah, that was not a removable expander. I wanted to do one for him because recognizing the smallness that underdeveloped maxilla was killing me. I wanted a removable. I couldn't talk him into it because he knew he couldn't wear it well. And so fine, I didn't want to force it. But we did aligners alone, and aligners alone in my world are dentoalveolar growth and change. But in his case, you could see it was amazing how much it did for him. So we're very happy to be able to treat that case with aligners alone. It was a learning curve there for how much you can really do. And in that case, it showed they can do a lot given a nice technique.
And everyone wants to know the removable expansion appliance that's used, and I'm just going to hold up mine. And I know Dr.
Yeah, you're
Gross,
holding one of them.
You're a user as well. Kevin Ohlendorf with Ohlendorf Appliance Labs. We are thrilled with his work.
I make them with Kevin Ohlendorf at Ohlendorf Appliances. It doesn't really have a specific name. It's a generic removable growth and development appliance.
Works well.
So the question
Works
is,
really
people,
well.
Yeah.
people age 60 and above can have expansion of the jaws?
Yeah,
That's
so
three
it's
question
interesting.
marks.
Yeah, 3 question marks, right? And I know, you know, I was taught the same thing in dental school. It turns out we were misled on the maxilla. And so when you start to get bone dynamic textbooks and then start learning about bone dynamics, you start learning the difference between the skull bones and the maxilla. And there's a big difference. So in the skull, we have full fusion. So in the skull, the sutures go through full fusion. It begins at age 2, believe it or not. And that's because at age 2, the brain is 80% grown. So if the brain is 80% grown at age 2, the sutures begin to fuse and they work their way towards the fontanelles. So it's a fancy word, but anywhere 3 bones meet is the triangle. And that little triangle, there's one here and there's one in the back. That's a fontanelle. It's the last place to fuse. So you have the whole thing coming together. That's finishing at somewhere between 25 and 30 years old. So the skull bones go through full fusion, whereas the maxilla is a completely different animal. None of the maxillary sutures fuse. They mature. They do not fuse like the skull bones fuse. So the maxillary sutures mature without fusion, which means they have the opportunity with an appropriate stimulus to then grow and be altered. And so you can grow a maxilla during the first 7 decades of life. So full maturity of the maxillary sutures doesn't occur until 7th decade. You have a lot of time to manipulate the maxilla. All you need is an appropriate appliance and then a technique to help kind of grow the maxilla and not be forcing teeth around. So yeah, those 2 things can be done nicely.
I may be stretching that a little bit. I'm 69.
Oh, shucks, we better get started tomorrow. Come on down.
We're working on it.
Someone wants to know, is this something general dentists can do, or do we need to refer out?
Oh, I'm a general dentist. I'm just a dentist. So I am just a dentist, but I've been doing this for 18 years. So it took a long time to get this all together, as you had to go here, there, and everywhere to learn what is available. And if you put in the effort to find the type of learning that is involved with growth development of the bones at any age and expansive and additive techniques, it's out there for you. And then sure enough, if you do all of this and learn from everywhere you're supposed to and do a nice job of it, you can have the same results and put together a nice, piece of education. So I now teach it, which I'm happy to do, because the more GPs that offer this, the better. So this has basically taken over what I do in my office, because I'm 18 years into this. I do very little restorative dentistry now. I rarely make a crown or a filling or anything like that. Mostly it's going to be growth and development in the 3-year-old to up category. And it's growth and development followed by teeth. So foundation followed by teeth, and all of it related to sleep and breathing and airway and nose breathing being the priority. So this can, be a wonderful thing for a GP office. In my world, I believe that the GP is probably best suited to do this.
And what about snoring? Does this fix the problem?
It depends. Sometimes it depends on where you're getting the snore from. And so, a snoring patient is going to show up underdeveloped. So you're probably going to have an underdeveloped set of jaws with either some crowding or that malocclusion. You're going to have to find that restricted frenum, and it could be the lower lingual, it could be the upper labial, it could be the buccal frenum. You're going to have to do an ENT into the nose with a nasal scope to make sure you find out what's going on in the nasal chamber. Somewhere there is airflow resistance, somewhere there is tissue that is vibrating, and you're getting a sound. And so as soon as you start to grow and develop the jaws, there's the opportunity to relieve the snoring. It's pretty much like everything else. You're not promising things, like it would be wrong to promise the patients anything, but in the end, what you're doing is you're delivering the growth and development to treat their malocclusion, to deliver more tongue space, to help the breathing, and then the musculature. And next thing you know, when all of those things start coming together, you figure out how much can you resolve in the symptom category. It turns out a lot of these symptoms go away. TMD full resolution, absolutely TMD full resolution. I don't have a single patient that has any single TMD symptom after you give the maxillary growth to that patient. In the snoring category, it's not 100%. In the OSA category, not 100%. So you're going to be making improvements in those patients. And I have had the experience of having OSA disappear. That's an opportunity that's happened. I've had significant AHI changes. I've had significant snoring decreases, but it's not the same as the TMD where it's an absolute pretty much 100% resolution across all patients.
What's your opinion of MSE?
Yeah, so, I don't do those types of procedures where you're doing implant-based surgical expansion in the maxilla. I know they work, but it's too traumatic for me. So I'm trying to stay out of the surgery category. So predominantly I do non-surgical orthopedic and orthodontic technique, and I enjoy non-surgical techniques. MSE and SARPI and MARPI, all those things, you'd probably have to look at programs that teach that to learn more about it and figure out if it's something for you. I'm not into the traumatic pathway.
And someone wants to know who made the Maryland Bridge on John's case.
Can I say the lab that made it? Is that okay to?
Sure.
Kawata Pandent in New Jersey. And I think they're in Florham Park or Cedar Knolls, but Kawata is Kuwata, Pan, P-A-N, Dent. Kawata Pandent. I've been using that laboratory for 29 years, and that's the only laboratory I use for restorative techniques. They're amazing.
Wonderful. And what about the Myo-Munchie? What's your opinion on that?
The Myo-Munchie, I'm sure it's wonderful. I've never used one. So anything that is promoting proper muscle use, I think if you're going to use that, you probably should work with a myofunctional therapist to make sure you're using it appropriately. Because just because you can chew on something doesn't mean you're doing it right. When soft tissue dysfunction means using the muscles improperly. So I think if you're going to use a Myo-Munchie, make sure you're getting training so you're doing it right.
Okay. Is it normal to have ortho treatment lasting from 9 years to 18 years?
No, that would not be normal. 9 to 18 years. You mean 9-year-old to 18-year-old?
I think 9 years old to 18 years. I mean, I'm okay. Reading it just like you're hearing.
Like a 9-year? Yeah, no, no, I don't know. I hope that wasn't the assumption that my case that I showed, the child who was 9 to 17, he wasn't treated from 9 to 17. We did a year when he was 9 to 10, then he got a guidance appliance, took a break. When he was 14, we used 17 aligners. His total treatment time was 1 year plus 8 months. So 20 months of treatment time, but we were just showing over time how he's grown and developed, and his wisdom teeth are now in. So I hope that wasn't referring to my patient. I was trying to make it clear about the treatment times, and they are very short, believe it or not. And then in between, you're not doing treatment in between, you're wearing a guidance appliance. The patient who's being treated from 9 to 18 years old in orthodontics, that's what happens when you're fighting with the teeth and not addressing the musculature, because the teeth don't move just because you put brackets and wires on them, and they certainly don't move appropriately if you don't address the musculature. The teeth are in the wrong place because the muscles are misbehaving, and the muscles are stronger than the bracket and wire forces. So typically you see a lot of collapse, meaning you put a bunch of braces on and the back teeth fall in because the cheeks are hyperactive. When the cheeks are hyperactive, everything collapses, and you spend a lot of time trying to fix it. So ortho goes, it can certainly go awry when you get rolling, and then all of a sudden the years are going by and the 9-year-old's turning 18 and you've been in 9 years of continuous treatment. That's a failure to address the soft tissue dysfunction. That's probably a patient who is struggling with nose breathing, probably has a frenum issue, a restriction. The tongue is limited in its mobility and ability to protect the inside and the development of the arch. And the brackets and wires are activating histology, so things are movable, but working with the musculature, meaning the inside is weak and the outside strong, so everything is staying collapsed, and it's very difficult to unravel the malocclusion when you're working against poor musculature. The answer is, a different pathway.
And then there's a lot of concern for people who don't know about lack of, let's say, recession or periodontal attachment loss in the expansion process. Can you address that? Yeah,
do you think it's related to the older patients who have recession at the beginning of treatment, or to protect against getting recession during treatment?
Well, I guess, have you experienced any periodontal attachment loss or recession in the expansion process?
Oh, no. So if we begin treatment on anyone in any age group, we not only do not get periodontal loss or change, we get regrowth or healing of periodontal structures based on having an appropriate technique that allows for a cycling of pressure and tension to get more bone growth and deposition than resorption. So the best way to have recession and or fenestration, dehiscence, root damage, the things that are the risk factors for orthodontics, let's say, is to use fixed appliances and have a constant force. So braces are like that. If you put on fixed appliances and have a constant force, you do get resorption on one side and you get deposition on the other, but that's an absolute force with constant pressure. So now you've got this pressure tension theory working against you. If you have removable techniques, when you put something in your mouth, you're growing because you tend to be looking for bigger. So you apply something that produces a force and it's nice and gentle, but it's pushing out. Now, when you take it away, when you take it out, there's relaxation. So things are recovering. Well, an outward push and a recovery is then cycling the pressure and tension, because anytime things are recovering, relapse is a form of recovering. And when you wear your expander, it's pushing out. So the pressure is on the buccal, the tension's on the lingual. When you take your appliance out and things are relapsing, well, now the pressure's on the lingual and the tension's on the buccal. Now you are cycling pressure and tension as you're growing. So you should see an improvement in the periodontal structures and in the bone. So when you're in the removable orthopedic or orthodontic category, you can help heal the periodontal status of a patient. But when you're in the fixed category, you're going to be in the category of causing more recession and or bone loss and or fenestration, dehiscence, or root resorption. So you have to be very careful with fixed orthodontics. They're not kind to the periodontal structures. And a lot of the research shows that, which is why expansive orthodontics usually don't go very well with fixed techniques. Because if you're doing fixed and you're trying to move things really far out, the constant pressure damages all the buccal tissue. So yeah, orthodontics alone with fixed techniques aren't really meant to develop the arches really wide, which is why the arch wires go straight back and they maintain a narrow. They're just trying to line up in this kind of frame. If you're that narrow, you make the teeth lined up, and if they don't all fit, you take out 4. You line up the rest, because you know if you try to go wider with fixed techniques, it blows out the bone and you have big trouble. So removable is the answer. Cycling pressure and tension is the key.
You know, the orthodontists don't seem to comply with all these things. I think the speed of doing things and the fact that it's removable makes a whole different story here.
Yeah, well, their focus is on the teeth. Most of them focus on the teeth. If you're focused on the teeth, then you're condemned to working in a small foundation, so you're limited by what you can do. If you're working on the foundation first, well, now you're not only limited, you can heal that patient.
What is the right age to start intervening?
The day you meet the child, because they're underdeveloped, unless you found a unicorn.
Right.
So it's 3. In my office, it's 3. The myofunctional therapy community is very good at working with even 2 to 3. So you can get in there a little bit earlier if you wanted to, but 3 years old works pretty well for us. And by 3 years old, you have an underdeveloped set of jaws already and a long list of symptoms.
And Dr. Silver is dying to know if she can come and get treated. This is me, she's saying, and I have known for years, which is why she won't let any of her kids get extractions.
Right. Yeah, no extractions for the children. No one needs an extraction. In fact, the goal really is all 32 teeth. So you want to see someone who can tell you with confidence that they have a technique that erupts more of the wisdom teeth into function than less. And so I'm that office now. We send very few kids out for wisdom tooth extractions. Those are the ones we treated early. So if we treat the child early, the wisdom tooth extraction rate is very low. Most kids can have them come in. One of our favorite things to do, actually, when the first wisdom tooth starts to poke in, it can be irritating and that tissue can be kind of thick. I send them over to the periodontist now because they have a nice laser. And what they do is they just laser off the top of the tissue and it's gone and they're fine a day later. It's like a pizza burn for a day, but then the tooth can pop right into place. So what used to be a referral for 4 wisdom tooth extractions is now a referral to the periodontist. Just take off that tissue on the top and get the discomfort from being months of coming in, erupting tooth pain to just a day. So that's a nice step. We're happy to make that referral.
How do you handle the occlusion during the expansion process in an adult? How are the teeth responding to that?
Oh, really well, you know, because the day before they get their expander, they have the most horrific malocclusion you could imagine. And the day the expander goes in, every single day that goes by, they're heading in the right direction. So basically, it's like taking a 500-mile drive, you know, and how's that 500-mile drive going after 1 mile? It's going great because I'm heading in the right direction. And every mile that goes by, sooner or later, you're there. Well, every day that goes by, you're heading towards the correct malocclusion. So when you're using removable expansion appliances to grow the foundation, and then coordinate the teeth second, at no point in time are you worse off. you're always a step in the right direction, heading better and better and better. And most of the evidence comes from the patients who have their symptoms. In the TMD category, the symptom resolution begins in weeks. And so after having decades of discomfort and pain within a matter of weeks, that can fade away. And next thing you know, all of a sudden you have that jaw growth and development. And while they were locked into this crazy malocclusion, you're going to coordinate those teeth towards the end, but at no point in time are they worse off or more uncomfortable or having difficulties or troubles. So it's not about handling the occlusion during treatment. It's you're treating the malocclusion from where they are to where they should be. And the end result should be like a type it on type of finish where they're perfect. But when you start out in that horrific malocclusion they have, and you're working your way towards, you're always heading in the right direction when you're dealing with foundation first and tooth coordination second. It's a really nice pathway to take.
When do you decide to expand the mandible as well?
So in children, every one of them. So every kid gets a set of expanders because when the kids come in and they're measured, usually you need a minimum of 8 millimeters of expansion in both arches, or you're going to find that some of them need 10, 12, or 16, depending upon where they are. So a child needs to get their way up to 40 before they're 12 years old. And that 40 mark is in between the upper first molars. So I like to use Dr. James McNamara's research out of the University of Michigan as a marker. Dr. Bogue has some nice research for the primary dentition, showing where a 4-year-old should be. And then Dr. McNamara kind of shows where the jaw growth kind of progresses to actually get all 28 teeth without any orthodontics or intervention and having a good healthy bite. You want to be 40 millimeters between those upper first molars. And then if you really want to have your wisdom teeth erupt, you better get over 40 and get towards 45 millimeters. So most kids need at least 8 millimeters of expansion, and some of them upwards of 10, 12. So you end up with 2 expanders. You can't use an upper expander and get 8 millimeters. What are you doing with the lower? But the lower teeth are trapped under the upper jaw. So unless you have a posterior crossbite bilaterally, you're going to use both expanders. And even in a posterior crossbite bilaterally, when you get the upper where you think it should be in that bite and you measure again, you're still underdeveloped. So both jaws get, so kids, upper and lower expander is a routine. I do not do upper only expanders. That's useless, especially if we're trying to get, better breathing and sleeping and resolve the jaws enough to have all 32 teeth. As far as adults go, more and more the adult can have the upper removable expansion appliance with lower aligners, because lower aligners are wonderful at dentoalveolar change, and you can get all of those millimeters covered by a lower clear aligner. So sometimes in adults, we do make a lower removable Schwartz appliance to start that uprighting or tipping process for us. And that's fine. There's nothing wrong with either direction. So I would say, because the lower appliance is a little more, I don't want to say uncomfortable, but it can be irritating a little bit occasionally. So the lower appliance isn't the most comfortable one to make. I like to go with the clear aligners mostly, but if I really have lingually inclined teeth and I need a little bit of a boost, I'll get the lower Schwartz in there too.
And then Dr. Cachefe wants to know, can expansion relapse in kids, both palatal and nasal floor expansion? Can it relapse without myofunctional therapy?
Yeah, there are different ways to relapse. One of them would be if you don't help convert to nasal breathing, because if you do all that work in a child and then you still have a mouth breather at the end of that, well, then the idea is the mouth breathing drops the tongue and the tongue does not promote the full growth. You'll go right back. So the process of delivering the expansion comes with, first of all, the diagnosis of the frenum, because if you have a lingual frenum issue, it needs to be released. You're going to need myofunctional therapy as well. So most children need the frenum released, and all of the kids need some myofunctional therapy. So when you convert that child to a nose breather with proper tongue function, then when they close and they breathe through their mouth, their tongue is what's growing them. So you go from expansion appliances, so fixed upper and lower expanders, you graduate to guidance appliances. So you have nasal hygiene going on the whole time, so they can breathe through their nose, get it clear. Then you've got your frenum release, your myofunctional therapy. But when the expanders disappear, after giving them their 8, 10, or 12, or 16 millimeters, whatever you needed, they get a myofunctional guidance appliance to wear for a couple hours a day plus overnight. That also helps train the tongue and the breathing. So those guidance appliances allow for continued growth and development. Otherwise, yeah, if you just did expanders, took them away, chances are you're going to go back most of the time. And I'm pretty sure there's no less than 32 papers published on upper expansion is fruitless because afterwards it goes back. Well, of course, if you only use an upper expander, you can't even go that far. Number one. Number two, none of those papers address the breathing, the musculature. So you expanded something and the musculature was dictating to go back. So we take away your expander. What are you going to do? Relapse. So you got to put in the pieces of the puzzle to treat the cause, and then you don't have relapse. So we don't experience relapse.
And then with overclosed patients, are you also opening up their vertical dimension?
Yeah, that happens by the expansion process. So when you upright your bottom teeth and you expand the upper, you're getting the inclination to go away. And relieving inclination opens the bite automatically. So the lower teeth, when they're tipped up, that raises the occlusal plane. When the upper teeth are tipped down, that lowers the the back teeth meet sooner. When the back teeth meet sooner, your deep bite goes away. So you're always treating the overclosed patient by growth and development and posterior uprighting as opposed to anterior intrusion. I do not do anterior intrusion because the patient does not have over-erupted teeth. They have overclosed jaws. And an overclosed jaw compresses the tongue and makes the tongue space even worse. So you always want to correct the overclosed patient by opening the bite. Posterior uprighting is the pathway to opening the bite.
And can a lingual frenum issue alone cause mouth breathing?
Well, a lingual frenum issue causes or delivers limited mobility of the tongue. Limited mobility of the tongue delivers a lack of jaw growth and development. So the lingual frenum issue doesn't necessarily cause mouth breathing. The mouth breathing is triggered by the underdeveloped jaws delivering nasal airflow resistance. So if you have a lingual frenum issue, you have a second component to have underdeveloped jaws. The first pathway for underdeveloped jaws and the predominant pathway to underdeveloped jaws is the early soft diet. So the early soft diet delivers a weakness in the tongue and a dysfunction of the tongue. And next thing you know, with softer food, less muscle use, less bone growth, and then it recruits the extraoral muscles for the swallowing that the tongue isn't doing properly. So now you have the inside is weak and the outside is strong. So you're going to kind of compress things in and raise the vault. So the lingual frenum attachment or restriction is a secondary issue, and it does cause limited jaw growth and development. It's second to the early soft diet.
Okay, I have two more questions and
Sure.
related to TMD. Any special concerns or treatment for discs that cannot be recaptured? Limited painful opening, no joint noises?
So I have to say I do not have an experience where the disc could not be recaptured. So if I meet a patient that has a disc that is displaced, I will send them to a TMD specialist, so to speak, to recapture the disc, stabilize the patient, send them back to me. I can do the growth and development. I typically do not start the treatment on someone with a disc that's displaced. So I'll send them, they'll come back, then we treat. Any patient that has a history of this displacement and then is referred to me, usually it's recaptured and then we treat. I don't have an example of not being able to recapture that disc, but I usually let someone else do that for me and then they come back in and we do the growth and development.
Okay, and last question from our chat. Was there a change in bruxism in those patients with TMD problems?
Every one of them. Yeah, every patient that will clench and grind their teeth, the more room you have for the tongue and the better their breathing is, the bruxism will decrease. And so primarily the bruxism comes from the nasal airflow resistance. And it's part of the mechanism of the compensation to breathe better. So nasal airflow resistance, the first trigger is mouth breathing. And that's obvious, right? If the air isn't flowing well through your nose, your body opens your mouth to help out. It's interesting though, Dr. Gerald Simmons, who I learned this from him. Dr. Gerald Simmons is triple board certified in neurology, sleep medicine, and epilepsy. And what he learned in his PSG studies at Stanford University, and now he's operating sleep clinics in Houston, what he learned was that when there's nasal airflow resistance and the body opens the mouth, it almost never does the patient have a decrease in airflow resistance. So mouth breathing doesn't decrease airflow resistance. It just is a compensation for making sure air can get in when the nose doesn't breathe well. But what he noticed right away was that in providing both thoracic and esophageal leads to measure airflow and pressure, as well as myography to record muscle activity over the night's sleep, he learned that when the mouth opens and the airway resistance doesn't drop, masseter fires first. The very first muscle is masseter. It fires to drive the jaw forward and up and closed again to bring the tongue with it. But that doesn't usually provide a decrease in resistance. So then all of the other muscles of mastication start firing. And when the jaw starts to shake, so does the tongue. And as the jaw moves, the tongue moves. And what you can read on the graphs is that the airway, the airflow resistance, there will be periods of decrease based on the tongue's position. So as the lower jaw is shaken around, we call bruxism, the lower jaw movement moves the tongue. But as the tongue is moving, there are periods where it's in a better position for air to get by it. And then there are periods where it's worse for air. But anytime the air flows a little better behind the tongue, what happens is the airflow resistance decreases. And as that decreases, it shuts the whole mechanism down. So you stop. But what happens when you've been clenching and grinding? You're in the closed position. So the air got to go by your tongue better. The whole mechanism shut down, but now you're back to closed. The airflow resistance is going to climb again. The vicious cycle of bruxism is an airway protective mechanism, and it repeats itself throughout the night. So you will be clenching and grinding as long as you cannot breathe well through your nose. So it's an airflow resistance and pressure issue. And the moment you resolve the resistance and the pressure issues, which is usually from growth and development of the jaws, you have a decrease in your bruxism. So mostly we deliver clear retainers to our patients. The clear retainers we deliver, the patients use them for 2 years each. And over 2 years' time, when they give them back for us to look at them, they have no marks on them. So I've never had to make a night guard after treating someone orthopedically and orthodontically, because if you solve the breathing throughout that mechanism, you don't have your clenching and grinding anymore. So we have patients who have had night guards forever. They don't have them anymore after treatment. And then of course, splints, no more of that because there's no TMD symptoms. But if you want to see a nice clear aligner after 2 years with no marks on it from a patient who used to crush night guards, all you have to do is give them more room to breathe. And if you can correct the breathing, you can correct the bruxism. That decreases with better airflow.
Wonderful. Well, what a great way to end. Dr. Gross, did you have another question before I go ahead and share some updates?
Well, I just want to say that's the best explanation of bruxism I've ever heard. I'm going to want to listen to that again.
It was a short version. It usually takes an hour to go through that whole mechanism, but I tried to do it in 2 minutes.
Yeah, I'm sure, but that was really informative there. I think you want to get move on, so I'll delay my questions. I've got 1,000 questions, but maybe we'll do this another time.
Sure. Thank you so much. And also
Thank
we
you.
do have archived podcasts. So I did send the link in there where we do have an hour on airway and bruxism with Gerald Simmons. So that's a really great resource. We have a lot of experts. We have Dr. Gelb talking about TMD and the night guards and the appliances and all of that. So please look at, I put it in the chat, airwayhealthsolutions.com/podcast for a lot of great information from leading experts. So I had about 20 questions on where do we go from here? How can we get the training? And that's why Dr. Miraglia and I teamed up to provide a technique course we call a mini residency for pediatrics and adults. You can take either the courses together, or if you don't treat children, you can just take the adult course. But we do recommend both days together. Our next courses are November 12th and November 19th. They are filling fast because we don't have any this October. And then we have some scheduled in the new year for the 21st and the 28th. In this course, Dr. Miraglia, you just want to give a brief overview, high level of the pediatric and then the adult course?
Yes. So in the pediatric course, it's a technique course. So we learn all of the diagnostic tools that are needed to make a nice diagnosis on the children. Then, of course, after that, it's how do we get through a nice consultation with the parents? And then after that, what are we doing to treat them? And that includes everything from removable myofunctional guidance appliances, of course, the Frenum diagnostics and treatment to relieve the Frenum, the myofunctional therapy that's involved, expansion appliances, whether they're fixed or removable. Mostly in the pediatric, we do fixed expanders. When we're talking about adults, it's removable. And then, of course, what do we do after fixed expanders, which is guidance appliances to get them all the way to 12 and have fully developed jaws that can accommodate wisdom teeth as they get older. But the pediatric course takes you from diagnostics through treatment, and the adult same way, diagnostics and through treatment. But in the adult course, all of the appliances that are in the expansive orthopedic category are removable. And then when we get to the second part, coordinating the teeth, it's usually in the clear aligner category. So the adult course has a lot of clear aligner technique, because just because anybody can use a clear aligner, it's not the material, it's the technique. And so if you're misusing a clear aligner or have a poor technique, you can actually have an adverse outcome. But if you have a really good clear aligner technique, you can treat TMD to full resolution and have all these wonderful things happen. So we teach a fully expansive clear aligner technique in there. In the adult course, we do cover, of course, the sleeping, breathing category. We have even a couple of patients in there with the OSA. We also have in there the TMD category covered, which is pretty nice to show more cases in detail. How do you go ahead and develop a beautiful treatment of the TMD symptoms? So yeah, it's a pretty nice course that covers everything from diagnostics through treatment opportunities to have your patients heal.
Absolutely. And we also share a wealth of information with resources, references, articles, everything to get you rolling. We share a library of resources with you. So hopefully you can join us in November. And we're so excited because we're launching our first advanced course actually Friday and Saturday. So if you already took our pediatric and mini residency, we highly recommend you jump on this opportunity to learn the next level. And I won't go too far in the woods here. You can reach out to me if you're interested, but you do get a 60% discount off the carrier SLX system from Henry Schein Orthodontics, which is unheard of, right? They usually don't discount those prices. So that alone is really a great additive, but you will learn how to do fixed expansion in older children as well as braces in an expansive technique. The foundation will be treated first, and then it's just about tooth alignment with an expansive braces technique. So that's this week. It's not too late if you want to join us. We are thrilled. We just released a press release from early childhood curriculum with Dr. Kevin Boyd, the infamous Dr. Kevin Boyd. He treated Connor Deegan, which is a very famous story. You may want to Google that, the Connor Deegan story. He was the pediatric dentist who realized Connor was suffering from sleep disordered breathing and was able to help him tremendously. He basically saved his life, but he's joining Airway Health Solutions as faculty, and we have 2 brand new courses, which is basically a call to action because he really wants to get all preschool children treated, as many as he can. So we have a course on the pediatric validated airway risk assessment, December 10th. And also enjoy treating kids in your dental practice. I see a lot of resistance from general dentists. They're kind of afraid of them. So he's been doing this for 30 years, and he gives you his tactics and techniques for caring for the pediatric airway patient because you can make a difference. So please check out our website with his landing page, airwayhealthsolutions.com/Boyd. So we're thrilled to have him. I've also had many questions about how do we get trained as a myofunctional therapist, or I need a myofunctional therapist in my area. So I reserved that for this time, where we actually created a 2-day really intensive myofunctional training course, or perhaps you are just a beginning myofunctional therapist who wants additional training. This course has Brittany Sierra and Carice Laguerre. They're both superstars in their field. They walk the walk, they talk the talk. It's very interactive, and they really help you to integrate creating, I guess, being comfortable to being competent, which is really important in the field, as you know. So we're going to extend our promo. The AAPMD meeting was just this week, and I already have all the codes created. So I figured, let me just go ahead and extend this to our listeners only today for this study club. We're doing an exclusive offer where it's 10% off on our following courses. So we will send you an email with all this information, so please read it carefully. There's a lot to take advantage of, especially our upcoming courses. We got a lot of questions about how do we get clear aligner training or my team on board with clear aligner therapy. Well, if you're up for a live learn, we're going to be in Florida, Dr. Miraglia and I, teaching a full day live course at the Diplomat in Hollywood, Florida at the Dental Festival. So please learn more at clearalineru.com. We help the team and the doctor work together to integrate clear aligner therapy as a hidden solution for many common dental problems. So we hope to see you live. That would be incredible. But please visit clearalineru.com or reach out to me and I will send follow-up information as well. People are looking for airway dentists. Actually, I have Dr. Prevalence on with me tonight. He's one of our listeners, and I referred a patient over to him who from our locator. So it's airwayhealthsolutions.com/locator. And you can see we have our airway dentists throughout the country. We have many more now. But once you take our course, we put you on the map, and we do send you referrals. So it's really a great way to help people, but also help you practice and build your practice. We have upcoming Airway Health Solutions conversations. I'm really excited. Next week, we have Dr. Dania Tamimi, Understanding the Airway Through CBCT Imaging. She's a radiologist. I heard she's fabulous. Everyone's raving about her. So if you can, you'll learn a lot next week. If you want to join us again next Wednesday. October 27th, we have Dr. Kevin Boyd. He's going to be sharing more research on the origins of malocclusion and airway disorders. So you'll really get a deep dive from Airway Health Solutions on the causes of malocclusion and sleep disordered breathing. And then our own Dr. Jasmine Elmore, she's a graduate of our mini residency. She's going to be talking about the upper respiratory resistance syndrome. Okay, and Dr. Gross, let's talk about your GNYACD upcoming events. You plan ahead. I'm only on next week.
Well, gee whiz, you have a lot going on. That's just amazing. Congratulations on all your activities, and
Thank you.
and God bless you for doing all this,
Thank you.
both of you. Yeah, we have in the spring, sort of like a follow-up on this type of thing. We're going to have cosmetic cases where airway is involved, and we're going to go to from start to finish, and we're going to have a discussion about them. We have very bright dentists who are with us, and they're going to help us out, and we're going to be discussing those things. On June 17th, with the date on that spring 22 is not out yet, so look for our GNYACD.com webinar, or rather our website, and you'll be able to see the dates on that. And that's down here, our website. June 17th, we have a full day seminar. Dr. Stephen Katz and Kelly Fox-Galvani of Smile Potential. It's a blueprint for practice success. This is something that we've delayed 2 times because of COVID, and we're really looking forward to it coming up. I think this is really apropos talking about this now, because we have to motivate our patients to do something extra special when they might not even realize that they need something extra special. We have to let them, we have to inform them, then we have to motivate them. And Steve and Kelly are terrific at this. They worked with my office, and I've attended a lot of their lectures, and they're really great people. Now, going into next year, fall 22, this is something that will also fall into your audiences and our audiences categories. We're going to do a full day seminar on airway cosmetic, the airway cosmetic approach. We're going to have somebody of high renown, and I'm not saying that yet because it's a year off, so we'll see what happens with COVID and with people's schedules, but that's what we plan to do.
Wonderful. Well, thank you for sharing that. And thank you for sponsoring tonight's CE. Just so you know, we're just at 9:01. I apologize for running 1 minute over, but you had a lot of questions I wanted to address. You're going to be emailed a survey. And on that survey, you're going to enter the CE code, and the code is AHSNY. So please write that down. The deadline is October 3rd, Sunday, for submission to get your CE certificate. And you must be on our attendance list for the duration of the study club to receive the CE. Not my rules, so just don't kill the messenger. But we are so glad that everyone joined us tonight. This was really wonderful, and what a great idea to really combine study clubs. So if anyone else has another study club that they want to maybe collaborate like we did with the GNYACD, we'd be happy to collaborate with you. So reach out to me. Dr. Miraglia, thank you. Thank you again for your time and your wisdom and sharing with everyone all of your knowledge. Well, not all of it, but just enough to get them going. And we do hope we see you at other courses soon. Dr. Gross, thank you so much for this opportunity and for being such a great co-host. I had a lot of fun, and I hope you enjoyed it.
Very much. Thank you so much.
Great, and thank you.
Thank you, Ted.
Thanks, Ben. Lauren.
Thank you, audience. You guys were wonderful.
Thank you, everybody.
Interactive.